Welcome to Diabetes Management Evidence-Based Update. Diabetes mellitus represents one of the most significant chronic disease challenges facing healthcare systems worldwide, affecting approximately 23 million adults in the United States alone. This metabolic disorder, characterized by persistent hyperglycemia resulting from defects in insulin secretion, insulin action, or both, carries profound implications not only for the individuals living with the condition but also for the multidisciplinary healthcare teams responsible for their care. The landscape of diabetes management has undergone remarkable transformation in recent years, with advances in diagnostic precision, pharmacologic therapeutics, technology integration, and care delivery models fundamentally reshaping how clinicians approach this complex disease. For allied health professionals, including physical therapists, occupational therapists, nurses, and other rehabilitation specialists, the imperative to maintain current knowledge in diabetes care has never been more pressing. Conservative estimates suggest that up to 80% of patients presenting to outpatient physical therapy clinics have diabetes or significant risk factors for its development, while occupational therapists increasingly encounter individuals whose functional independence is compromised by diabetes-related complications. Nurses across virtually every practice setting now regularly manage patients requiring insulin therapy, glucose monitoring, and comprehensive self-management education. This ubiquitous presence of diabetes across clinical practice demands that allied health professionals possess not merely foundational knowledge but sophisticated understanding of contemporary evidence and emerging best practices. This continuing education course provides a comprehensive, evidence-based update on diabetes management specifically designed for the interprofessional healthcare team. Drawing upon the most current clinical practice guidelines, including the American Diabetes Association's 2026 Standards of Care, systematic reviews, meta-analyses, and landmark clinical trials, this course addresses the full spectrum of diabetes care from accurate diagnosis and classification through pharmacologic management, complication prevention, technology utilization, and team-based collaborative care. Particular emphasis is placed on the distinct roles that physical therapists, occupational therapists, and nurses play within comprehensive diabetes management, supported by the growing evidence base demonstrating the effectiveness of these disciplines in improving patient outcomes. The course content reflects the evolving understanding that diabetes care extends far beyond glycemic control. Contemporary management embraces a holistic, patient-centered approach that addresses cardiovascular risk reduction, renal protection, mental health integration, functional preservation, and quality of life enhancement. Allied health professionals are uniquely positioned to contribute to each of these domains, making their informed engagement essential to optimal patient outcomes. Upon successful completion of this continuing education course, you will be able to accomplish the following learning objectives. First, you will be able to distinguish the diagnostic criteria and clinical features of type 1, type 2, and atypical diabetes forms. Second, you will be able to identify at-risk individuals using evidence-based diabetes screening protocols. Third, you will be able to compare the mechanisms, indications, and benefits of SGLT2 inhibitors, GLP-1 agonists, and dual agonists. Fourth, you will be able to recognize common diabetes comorbidities and their age-related patterns. Fifth, you will be able to select appropriate diabetes technologies to improve glycemic control. Sixth, you will be able to match therapy and nursing interventions to specific diabetes patient populations. And seventh, you will be able to identify team-based strategies that reduce therapeutic inertia using the chronic care model. Let's begin Module 1, Foundations of Diabetes, covering pathophysiology, classification, and diagnostic criteria. We'll start with the definition and core pathophysiology of this condition. Diabetes mellitus encompasses a heterogeneous group of metabolic disorders unified by the cardinal feature of chronic hyperglycemia. This persistent elevation in blood glucose concentration results from fundamental defects in insulin secretion by pancreatic beta cells, impaired insulin action at target tissues, or most commonly, a combination of both pathophysiologic mechanisms. The consequences of sustained hyperglycemia extend throughout the body, progressively damaging the microvasculature supplying the retina, kidneys, and peripheral nerves, while simultaneously accelerating macrovascular atherosclerotic disease affecting the coronary, cerebral, and peripheral arterial circulations. The metabolic derangements of diabetes extend beyond glucose dysregulation to encompass disturbances in lipid and protein metabolism. Insulin deficiency or resistance promotes lipolysis. elevates circulating free fatty acids, and drives hepatic production of very low-density lipoproteins, contributing to the characteristic dyslipidemia observed in diabetic patients. These interconnected metabolic abnormalities establish diabetes as a systemic disease with far-reaching consequences for virtually every organ system, necessitating the comprehensive, multidisciplinary approach to management that forms the foundation of contemporary care. Now let's examine type 1 diabetes mellitus in detail. Type 1 diabetes results from autoimmune-mediated destruction of insulin-producing pancreatic beta cells, ultimately leading to absolute or near absolute insulin deficiency. While traditionally conceptualized as a disease of childhood, contemporary understanding recognizes that type 1 diabetes can manifest at any age, with a substantial proportion of cases, perhaps as many as half occurring in adulthood. Adults with new onset type 1 diabetes frequently experience a more gradual clinical course than children, with a period of preserved residual beta cell function that may delay the need for intensive insulin therapy and contribute to diagnostic uncertainty. The autoimmune pathogenesis of type 1 diabetes involves both genetic susceptibility and environmental triggers that remain incompletely understood. The presence of circulating autoantibodies directed against beta cell antigens, including glutamic acid decarboxylase, known as GAD65, insulinoma-associated protein 2, or IA2 zinc transporter 8, abbreviated ZNT8, and insulin itself, provides serologic evidence of the underlying autoimmune process and serves as the basis for distinguishing type 1 from type 2 diabetes in clinically ambiguous presentations. Approximately 85 to 90% of individuals with newly diagnosed type 1 diabetes demonstrate one or more of these autoantibodies at the time of diagnosis. Contemporary understanding has formalized type 1 diabetes as a disease occurring across three distinct stages, a conceptualization with important implications for early detection and emerging disease-modifying interventions. Stage 1 is characterized by the presence of two or more islet autoantibodies in an individual who maintains normal glucose tolerance. Such individuals are at high lifetime risk for progression to clinical diabetes, but may remain in this presymptomatic phase for years or even decades. Stage 2 represents the development of dysglycemia, impaired fasting glucose, impaired glucose tolerance, or mildly elevated hemoglobin A1C in the continued presence of autoantibodies, signaling accelerating beta cell loss and typically presaging progression to symptomatic disease within months to a few years. Stage 3 constitutes the clinical diagnosis of diabetes, meeting standard diagnostic criteria in the context of symptoms or metabolic decompensation. The clinical presentation of type 1 diabetes varies considerably with age and the rapidity of beta cell destruction. Classic symptoms include polyuria, polydipsia, polyphagia accompanied paradoxically by weight loss, and fatigue manifestations of the osmotic diuresis, cellular dehydration, and catabolic state induced by severe insulin deficiency. Approximately 30% of children with newly diagnosed type 1 diabetes present with diabetic ketoacidosis, a life-threatening metabolic emergency characterized by hyperglycemia, ketosis, and metabolic acidosis that reflects profound insulin deficiency. Adults may present with similar acute symptoms or may experience a more indolent course, particularly those with the variant termed latent autoimmune diabetes in adults, or LADA, in which residual beta cell function persists for an extended period following diagnosis. Now let's turn our attention to type 2 diabetes mellitus. Type 2 diabetes, accounting for 90 to 95% of all diabetes cases, arises from a fundamentally different pathophysiology characterized by progressive loss of adequate beta cell insulin secretion occurring against a background of peripheral insulin resistance. Unlike the autoimmune destruction of type 1 diabetes, beta cell failure in type 2 diabetes develops gradually through mechanisms that likely include glucotoxicity, lipotoxicity, oxidative stress, and deposition of islet amyloid polypeptide. The result is a disease trajectory in which insulin secretion becomes increasingly insufficient to overcome tissue resistance to insulin action, leading to progressive hyperglycemia. The epidemiology of type 2 diabetes has undergone dramatic shifts in recent decades, with particularly concerning trends among adolescents and young adults. Once considered exclusively a disease of middle and older age, type 2 diabetes now represents an increasingly common diagnosis in youth, driven by the parallel epidemics of childhood obesity and sedentary behavior. The incidence of type 2 diabetes among individuals aged 10 to 19 years increased by approximately 5% annually between 2002 and 2015, reaching 14 per 100,000 person years, with disproportionate impact on minority populations including American Indian and Alaska Native, Black, Hispanic and Latino, and Asian and Pacific Islander youth. The clinical presentation of type 2 diabetes differs markedly from type 1, reflecting the gradual nature of metabolic deterioration and the frequent presence of substantial residual insulin secretion. Many individuals with type 2 diabetes are asymptomatic at the time of diagnosis, with hyperglycemia detected through routine screening rather than prompted by clinical symptoms. When symptoms do occur, they tend to be less dramatic than the acute presentation typical of type 1 diabetes, though polyuria, polydipsia, blurred vision, and fatigue may be present. The absence of absolute insulin deficiency generally protects against diabetic ketoacidosis, though this complication can occur in type 2 diabetes under conditions of severe physiologic stress. Strong familial clustering characterizes type 2 diabetes, with 60 to 90% of affected individuals reporting first or second degree relatives with the condition. This heritability reflects the polygenic nature of the disease, with numerous genetic variants each contributing modest risk that becomes clinically manifest in the context of obesogenic environments and sedentary lifestyles. The association with obesity is particularly strong, with body mass index at or above 25 kilograms per meter squared present in the majority of cases, though important variation exists across ethnic groups, with some populations developing type 2 diabetes at lower BMI thresholds. Let's now discuss how to distinguish between diabetes types. Accurate classification of diabetes type carries substantial clinical implications, as the therapeutic approach, disease trajectory, and complication risk profile differ meaningfully between type 1 and type 2 diabetes. Unfortunately, the traditional dichotomous framework type 1 as a disease of lean children and type 2 as a disease of obese adults fails to capture the considerable overlap and heterogeneity observed in clinical practice. Misclassification occurs with troubling frequency. Studies suggest that up to 40% of adults who ultimately prove to have type 1 diabetes are initially diagnosed with type 2 diabetes and treated accordingly. The American Diabetes Association and other professional organizations have proposed systematic approaches to diabetes classification that integrate clinical features with laboratory testing. The AABBCC framework provides a structured mnemonic for features favoring type 1 diabetes, age less than 35 years at diagnosis, personal or family history of autoimmune conditions, body habitus with BMI below 25 kilograms per meter squared, background family history of type 1 diabetes, inability to achieve glycemic control on non-insulin therapies, and comorbidities such as immune checkpoint inhibitor therapy. While no single clinical feature definitively establishes diabetes type, the constellation of findings guides the decision to pursue confirmatory laboratory testing. Measurement of islet autoantibodies represents the cornerstone of laboratory-based diabetes classification. GAD65 antibodies demonstrate the highest sensitivity for detecting autoimmune diabetes in adults and should be measured first. If negative, additional testing for IA2 and ZNT8 antibodies may identify autoantibody-positive individuals missed by GAD65 testing alone. The presence of 2 or more autoantibodies is highly specific for type 1 diabetes and strongly predictive of progression to insulin dependence in those with recent onset disease. C-peptide measurement provides complementary information by quantifying endogenous insulin secretion. Because C-peptide is released in equimolar amounts with insulin from pancreatic beta cells, but is not present in exogenous insulin preparations, its concentration reflects residual beta cell function independent of insulin therapy. A stimulated C-peptide level below 200 picomoles per liter suggests severe insulin deficiency consistent with type 1 diabetes, while detectable or elevated C-peptide in the context of hyperglycemia supports the diagnosis of type 2 diabetes with ongoing endogenous secretion. Beyond the type 1 and type 2 dichotomy, diabetes may arise through diverse pathophysiologic mechanisms that warrant distinct classification and management approaches. Monogenic diabetes syndromes caused by single gene mutations affecting beta cell development or function collectively account for approximately 1 to 5% of diabetes cases and are frequently misclassified as either type 1 or type 2 diabetes. Maturity onset diabetes of the young, known as MODY, represents the most common form of monogenic diabetes, encompassing multiple subtypes with varying clinical features and treatment implications. Some forms respond well to sulfonylurea therapy, while others require no pharmacologic treatment at all. Secondary diabetes may develop as a consequence of diseases affecting the exocrine pancreas, such as chronic pancreatitis, cystic fibrosis, and pancreatic carcinoma endocrinopathies characterized by excess counter-regulatory hormones like Cushing syndrome, acromegaly, and pheochromocytoma or medication effects. Glucocorticoids represent the most common drug-induced cause of diabetes, though immunosuppressive agents, atypical antipsychotics, and increasingly immune checkpoint inhibitors used in cancer therapy may precipitate hyperglycemia through various mechanisms. Recognition of secondary causes is important because management often requires addressing the underlying condition in addition to achieving glycemic control. Let's review the updated diagnostic criteria for diabetes mellitus, which have remained largely stable in recent guideline iterations, reflecting the robust evidence base supporting established glycemic thresholds. The American Diabetes Association's 2026 Standards of Care specify that diabetes may be diagnosed in non-pregnant adolescents and adults by any of the following laboratory criteria: hemoglobin A1C of 6.5%, which is 48 millimoles per mole, or higher using a standardized assay fasting plasma glucose of 126 milligrams per deciliter, or 7.0 millimoles per liter or higher after at least 8 hours without caloric intake, 2-hour plasma glucose of 200 milligrams per deciliter, or 11.1 millimoles per liter or higher during a 75-gram oral glucose tolerance test, or random plasma glucose of 200 milligrams per deciliter or higher in the presence of classic hyperglycemic symptoms or hyperglycemic crisis. Confirmation of the diagnosis through repeat testing is recommended unless unequivocal hyperglycemia with classic symptoms is present, as this reduces the likelihood of misdiagnosis based on laboratory error or transient glucose elevations. When two different tests are available from the same sample and both exceed diagnostic thresholds, the diagnosis is confirmed without need for repeat testing. Conversely, discordant results warrant repeat testing of the abnormal test, with diagnosis established when the repeat confirms the initial finding. Prediabetes, representing an intermediate metabolic state conferring increased risk for progression to diabetes, is defined by hemoglobin A1C of 5.7 to 6.4%, fasting plasma glucose of 100 to 125 milligrams per deciliter, termed impaired fasting glucose, or 2-hour plasma glucose of 140 to 199 milligrams per deciliter during oral glucose tolerance testing, termed impaired glucose tolerance. Individuals with prediabetes warrant lifestyle intervention, annual monitoring for progression to diabetes, and in selected cases, consideration of pharmacologic therapy for diabetes prevention. Welcome to Module 2, Screening, Early Detection and Risk Stratification. Let's begin by examining screening recommendations for adults. Population-based screening for type 2 diabetes aims to identify individuals with undiagnosed disease or prediabetes who may benefit from early intervention to prevent or delay complications. The American Diabetes Association recommends that screening for prediabetes and type 2 diabetes be considered in all adults beginning at age 35 years, regardless of weight or other risk factors. This universal screening threshold reflects the rising prevalence of diabetes in the general population and the recognition that early detection and treatment may reduce the burden of diabetes-related complications. For adults with overweight or obesity, defined as body mass index of 25 kilograms per meter squared or higher, or 23 kilograms per meter squared or higher in Asian Americans, screening should be considered at any age when additional risk factors are present. These risk factors include first-degree relative with diabetes, high-risk race or ethnicity, specifically African American, Latino, Native American, Asian American, or Pacific Islander, history of cardiovascular disease, hypertension with blood pressure 140/90 or higher or on therapy for hypertension, HDL cholesterol below 35 milligrams per deciliter, triglycerides above 250 milligrams per deciliter, women with polycystic ovary syndrome, physical inactivity, and clinical conditions associated with insulin resistance such as severe obesity or acanthosis nigricans. 3 laboratory tests are acceptable for diabetes screening in adults: hemoglobin A1C, fasting plasma glucose, and 2-hour plasma glucose during a 75-gram oral glucose tolerance test. Each test has relative advantages and limitations that may influence selection in particular clinical contexts. Hemoglobin A1C offers the practical benefits of not requiring fasting and reflecting glycemic exposure over the preceding 2 to 3 months, though it may be affected by conditions altering red blood cell turnover and demonstrates reduced sensitivity in some populations. Fasting plasma glucose is highly reproducible and widely available, but requires an 8-hour fast that may limit patient compliance. The oral glucose tolerance test demonstrates superior sensitivity for detecting dysglycemia, but requires a 2-hour testing period and shows greater within individual variability than fasting glucose. When initial screening results are normal, defined as A1C below 5.7%, fasting glucose below 100 milligrams per deciliter, or 2-hour glucose below 140 milligrams per deciliter, repeat testing should occur at intervals of no more than 3 years. More frequent testing is appropriate when risk factors increase, such as weight gain, development of hypertension, or changes in metabolic markers. Individuals with prediabetes warrant annual testing given their elevated risk for progression to diabetes. Now let's address screening in children and adolescents. The rising prevalence of type 2 diabetes among youth has prompted development of risk-based screening recommendations for this population, though important controversies remain regarding the evidence supporting screening benefits. The American Diabetes Association recommends that risk-based screening for prediabetes and type 2 diabetes be performed in youth who have overweight, defined as body mass index at or above the 85th percentile for age and sex, or obesity, defined as BMI at or above the 95th percentile, and who have one or more additional risk factors. Risk factors warranting screening in youth include maternal history of diabetes or gestational diabetes during the child's gestation, family history of type 2 diabetes in first or second degree relatives, race or ethnicity associated with increased diabetes risk, specifically Native American, African American, Latino, Asian American, or Pacific Islander, and signs of insulin resistance or conditions associated with insulin resistance, including acanthosis nigricans, hypertension, dyslipidemia, polycystic ovary syndrome, or small for gestational age birth weight. Screening should begin after the onset of puberty or at age 10 years, whichever occurs earlier, reflecting the typical timing of youth-onset type 2 diabetes in the context of physiologic pubertal insulin resistance. If initial screening in youth is normal, testing should be repeated at minimum every 2 years, or more frequently if BMI is increasing or additional risk factors develop. The choice of screening test in pediatric populations follows the same options as in adults: A1C, fasting plasma glucose, or oral glucose tolerance test, though important considerations regarding test performance in youth merit attention. The sensitivity of hemoglobin A1C for detecting dysglycemia appears lower in children and adolescents compared with adults, potentially resulting in misdiagnoses when A1C is used as the sole screening test. Studies suggest that A1C may underestimate the prevalence of prediabetes and diabetes in youth, with some individuals demonstrating normal A1C despite abnormal glucose tolerance on oral glucose tolerance testing. Despite these limitations, A1C remains recommended for screening due to its practical advantages and established association with cardiometabolic risk. For adolescents with multiple risk factors and A1C in the prediabetes range of 5.7 to 6.4%, the oral glucose tolerance test provides additional diagnostic information that may identify individuals with early type 2 diabetes missed by A1C alone. The U.S. Preventive Services Task Force has taken a more cautious position on screening in youth, issuing an I statement, meaning insufficient evidence, for screening for prediabetes and type 2 diabetes in children and adolescents. This determination reflects the task force's assessment that while screening tests can accurately identify dysglycemia in youth, adequate evidence is lacking to demonstrate that early detection and treatment in asymptomatic children and adolescents improves health outcomes compared with clinical diagnosis at symptom onset. The discordance between ADA and USPSTF recommendations highlights the ongoing uncertainty regarding the optimal approach to diabetes detection in pediatric populations. Let's now discuss risk stratification for type 1 diabetes. The recognition that type 1 diabetes evolves through predictable pre-symptomatic stages has enabled development of risk stratification strategies that identify individuals at high risk for clinical disease before symptom onset. This approach carries particular relevance in first-degree relatives of individuals with type 1 diabetes, who carry approximately 15-fold increased risk compared with the general population, and in research settings evaluating disease-modifying interventions. The three-stage model of type 1 diabetes progression provides the framework for risk stratification. Stage 1, characterized by the presence of 2 or more islet autoantibodies with normal glucose tolerance, identifies individuals with established beta cell autoimmunity who carry high lifetime risk for progression to clinical disease. The risk of progression from stage 1 to symptomatic diabetes approaches 100% over a sufficient follow-up period, though the rate of progression varies considerably among individuals. Factors associated with more rapid progression include younger age at seroconversion, particularly below age 3 years, presence of multiple autoantibodies, and development of IA2 autoantibodies, which tend to appear later in the autoimmune process. Stage 2 represents the development of dysglycemia, impaired fasting glucose, impaired glucose tolerance, or hemoglobin A1C in the prediabetes range while autoantibodies remain present. This stage signals accelerating beta cell loss and typically presages progression to stage 3, or symptomatic diabetes, within approximately 2 years. The identification of stage 2 disease has become particularly relevant with the availability of teplizumab, an anti-CD3 monoclonal antibody approved to delay the onset of stage 3 type 1 diabetes in individuals aged 8 years and older with stage 2 disease. For individuals with pre-symptomatic type 1 diabetes in stages 1 or 2, the ADA recommends monitoring for disease progression through hemoglobin A1C measurement approximately every 6 months and annual oral glucose tolerance testing. The frequency of monitoring should be adjusted based on individual risk assessment, with more intensive surveillance for younger individuals and those with multiple autoantibodies or declining glycemic metrics. Continuous glucose monitoring can provide additional information predicting progression in children and adolescents with autoantibodies, though oral glucose tolerance test-based metrics remain more reliable for assessing progression risk. Now let's explore how to distinguish type 1 from type 2 diabetes at presentation. The overlapping clinical features of type 1 and type 2 diabetes at presentation create diagnostic challenges that carry important implications for treatment selection and patient counseling. Misclassification is common, with studies indicating that over 40% of adults who develop type 1 diabetes after age 30 are initially diagnosed with type 2 diabetes and treated with oral agents or lifestyle modification rather than the insulin therapy their condition requires. Clinical features that favor a diagnosis of type 1 diabetes include younger age at onset, specifically below 35 years, lower body mass index below 25 kilograms per meter squared, unintentional weight loss at presentation, diabetic ketoacidosis, and marked hyperglycemia with plasma glucose exceeding 360 milligrams per deciliter or 20 millimoles per liter. However, none of these features individually confirms type 1 diabetes, and substantial overlap exists between diabetes types. Notably, features traditionally considered characteristic of type 1 diabetes, such as ketosis without acidosis, osmotic symptoms, and family history of autoimmune disease, demonstrate relatively weak discriminative value when subjected to rigorous analysis. The AABB-CC framework provides a systematic approach to evaluating clinical features when diabetes type is uncertain. Age below 35 years at diagnosis favors type 1 diabetes, as does personal or family history of autoimmune conditions including vitiligo, thyroid disease, celiac disease, and others. Body habitus with BMI below 25 kilograms per meter squared suggests type 1 diabetes, while obesity makes type 2 diabetes more likely, though neither finding is definitive. Family background of type 1 diabetes increases the pretest probability of autoimmune disease. while extensive family history of type 2 diabetes favors that diagnosis. Inability to achieve glycemic control on non-insulin therapies suggests inadequate endogenous insulin secretion consistent with type 1 diabetes. Finally, certain comorbidities, including immune checkpoint inhibitor therapy for malignancy, increase the risk of autoimmune diabetes. Laboratory testing with islet autoantibodies is essential when clinical features are insufficient to confidently establish diabetes type. GAD65 antibodies should be measured first given their superior sensitivity in adults. If negative, additional testing for IA2 and ZNT8 antibodies may identify autoantibody positive individuals missed by GAD65 alone. In children and adolescents who are overweight or obese and present with hyperglycemia consistent with type 2 diabetes, testing a panel of pancreatic autoantibodies is recommended to exclude autoimmune type 1 diabetes. C-peptide measurement aids classification, particularly in individuals already receiving insulin therapy in whom autoantibody testing may be less informative. A random C-peptide obtained within 5 hours of eating with concurrent glucose measurement can replace formal stimulated testing for classification purposes. Stimulated C-peptide below 200 picomoles per liter suggests type 1 diabetes with severe insulin deficiency, while detectable or elevated C-peptide supports type 2 diabetes with preserved endogenous secretion. The very strong relationship between type 2 diabetes incidence and age means that even classic features of type 1 diabetes may have limited predictive value in older adults, among whom type 2 diabetes is so prevalent that it accounts for the majority of cases even in individuals with lean body habitus. Rapid progression to insulin requirement within 3 years of diagnosis remains strongly suggestive of type 1 diabetes regardless of age and should prompt reconsideration of the initial classification in individuals diagnosed with type 2 diabetes who experience early treatment failure. Welcome to Module 3, Pharmacologic Management, covering established and emerging therapies. Let's begin with an overview of treatment goals and selection principles. The pharmacologic management of diabetes has evolved substantially from a historical focus on glycemic control to a contemporary paradigm that considers cardiovascular risk reduction, renal protection, weight management, and avoidance of hypoglycemia, alongside glucose-lowering efficacy. This expanded therapeutic perspective reflects the recognition that patients with diabetes face elevated risks across multiple domains and that modern pharmacologic agents offer differentiated benefits beyond their glucose-lowering effects. Treatment selection should be individualized based on patient characteristics, comorbidities, treatment goals, and preferences, following a shared decision-making model that engages patients as active partners in their care. Factors influencing medication selection include the presence or absence of established atherosclerotic cardiovascular disease, heart failure or chronic kidney disease, need for weight loss versus weight neutrality, risk for hypoglycemia, cost and access considerations, and patient preferences regarding route of administration and dosing frequency. For most individuals with type 2 diabetes, lifestyle modification and metformin remain foundational therapies, with additional agents added to achieve and maintain glycemic goals. However, contemporary guidelines increasingly emphasize the selection of add-on therapy based on cardiorenal risk profile rather than glucose-lowering potency alone, recommending agents with demonstrated cardiovascular or renal benefits in patients with or at high risk for these complications, regardless of hemoglobin A1c level. Now let's examine GLP-1 receptor agonists in detail. Glucagon-like peptide-1 receptor agonists represent a transformative class of diabetes medications that have rapidly assumed a prominent role in treatment algorithms based on their favorable efficacy, safety, and cardiorenal outcomes profiles. These agents mimic the effects of endogenous GLP-1, an incretin hormone released from intestinal L cells in response to nutrient ingestion that enhances glucose-dependent insulin secretion, suppresses glucagon release, slows gastric emptying, and promotes satiety. The glucose-lowering efficacy of GLP-1 receptor agonists is substantial, with typical hemoglobin A1c reductions of 1.0 to 1.5% depending on the specific agent and dose. This glycemic benefit is accompanied by clinically meaningful weight loss, generally 2 to 6 kilograms with standard doses and considerably more with higher doses approved for obesity treatment, attributable primarily to reduced food intake resulting from centrally mediated appetite suppression and delayed gastric emptying. Beyond metabolic effects, Several GLP-1 receptor agonists have demonstrated reductions in major adverse cardiovascular events in dedicated cardiovascular outcomes trials. Liraglutide, semaglutide, and dulaglutide have each shown significant reductions in the composite outcome of cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke compared with placebo, establishing this class as preferred therapy for patients with type 2 diabetes and established atherosclerotic cardiovascular disease or multiple cardiovascular risk factors. The safety profile of GLP-1 receptor agonists is characterized predominantly by gastrointestinal adverse effects, including nausea, vomiting, diarrhea, and constipation, which occur in a substantial proportion of patients but are generally mild to moderate in severity, tend to diminish over time, and can be mitigated through gradual dose titration. More serious but rare adverse effects include pancreatitis, for which patients should be monitored and the medication discontinued if suspected, and gallbladder disease, including cholelithiasis and cholecystitis. GLP-1 receptor agonists carry boxed warnings regarding the risk of thyroid C-cell tumors based on findings in rodent studies. These agents are contraindicated in patients with personal or family history of medullary thyroid carcinoma or multiple endocrine neoplasia syndrome type 2. A network meta-analysis found a modestly increased risk of thyroid cancer associated with GLP-1 receptor agonist use, with an odds ratio of 1.58 and 95% confidence interval of 1.36 to 2.50, though the absolute risk remains low. Importantly, GLP-1 receptor agonists do not cause hypoglycemia when used as monotherapy or in combination with metformin, as their insulin-stimulating effect is glucose-dependent. This favorable hypoglycemia profile makes them particularly attractive for patients in whom hypoglycemia carries elevated risk or concern. Now let's turn to SGLT2 inhibitors. Sodium glucose cotransporter 2 inhibitors constitute another cornerstone class of contemporary diabetes pharmacotherapy, offering a unique mechanism of action that provides benefits extending well beyond glucose control. These agents inhibit SGLT2 in the proximal renal tubule, reducing glucose reabsorption and promoting glucosuria, thereby lowering blood glucose independent of insulin secretion or action. The glucose-lowering effect of SGLT2 inhibitors is moderate, with typical A1C reductions of 0.5 to 0.8%, and is dependent on renal function such that glycemic efficacy diminishes as glomerular filtration rate declines. However, the cardiorenal benefits of these agents persist even at levels of kidney function where glucose lowering is minimal, indicating mechanisms beyond glycemic control. SGLT2 inhibitors have demonstrated remarkable benefits in cardiovascular outcomes trials, particularly for heart failure outcomes. Empagliflozin, canagliflozin, and dapagliflozin have each shown significant reductions in hospitalization for heart failure, with benefits observed both in patients with and without prevalent heart failure at baseline. These findings have extended the indications for SGLT2 inhibitors beyond diabetes to include heart failure with reduced or preserved ejection fraction, regardless of diabetes status. The renal protective effects of SGLT2 inhibitors represent another distinguishing feature of this class. Multiple trials have demonstrated that SGLT2 inhibitors slow progression of diabetic kidney disease, reducing the composite outcome of sustained decline in estimated glomerular filtration rate, end-stage kidney disease, and renal death. Current guidelines recommend SGLT2 inhibitor therapy for patients with type 2 diabetes and chronic kidney disease, regardless of glycemic control, recognizing the kidney protective benefits as independent of glucose-lowering effects. The safety profile of SGLT2 inhibitors includes several class-related concerns that warrant attention. Genital mycotic infections represent the most common adverse effect, affecting up to 10% of women and 2 to 3% of men, and are generally manageable with topical or oral antifungal therapy. Diabetic ketoacidosis, while rare, occurring in less than 0.1% of patients, can occur with SGLT2 inhibitors even at relatively modest glucose elevations, a phenomenon termed euglycemic DKA, and warrants particular vigilance in settings of acute illness, reduced oral intake, surgery, or recent insulin dose reduction. Volume depletion and orthostatic hypotension may occur, particularly in older adults and those receiving concurrent diuretic therapy, and should be anticipated with appropriate patient counseling and monitoring. In pediatric populations, clinical trials of SGLT2 inhibitors, specifically empagliflozin, dapagliflozin, and canagliflozin, have demonstrated safety profiles consistent with adult data, with clinically meaningful reductions in A1C and a low risk of severe hypoglycemia or diabetic ketoacidosis. Let's now discuss dual GLP-1 and GIP receptor agonists. Tirzepatide represents a novel therapeutic approach combining agonism at both GLP-1 and glucose-dependent insulinotropic polypeptide, or GIP, receptors, achieving unprecedented efficacy for both glycemic control and weight reduction. GIP, like GLP-1, is an incretin hormone that potentiates glucose-stimulated insulin secretion, but also appears to enhance the weight loss effects of GLP-1 receptor agonism through mechanisms that remain under investigation. Clinical trials of tirzepatide have demonstrated A1C reductions of 2.0 to 2.5% and weight losses of 15 to 25% at higher doses, substantially exceeding the effects observed with GLP-1 receptor agonist monotherapy. These findings have positioned tirzepatide as a powerful option for patients requiring substantial glycemic improvement and weight loss. The adverse effect profile of tirzepatide resembles that of GLP-1 receptor agonists, with gastrointestinal symptoms nausea, vomiting, and diarrhea being most common. In a pediatric trial of adolescents with type 2 diabetes, tirzepatide at doses of 5 mg and 10 mg weekly produced clinically meaningful improvements in A1C and weight at 30 weeks that were sustained at 52 weeks, with gastrointestinal adverse events being most common, consistent with adult experience. Tirzepatide does not yet have regulatory approval for pediatric use. Now let's briefly review DPP-4 inhibitors. Dipeptidyl peptidase 4 inhibitors offer a more modest glucose-lowering effect through oral administration, making them an option for patients who cannot tolerate or access injectable GLP-1 receptor agonists. These agents inhibit the enzyme responsible for degrading endogenous GLP-1 and GIP, thereby enhancing incretin activity, though to a lesser degree than achieved with pharmacologic GLP-1 receptor agonist doses. The typical A1C reduction with DPP-4 inhibitors is 0.5 to 0.8%, and these agents are weight neutral. They do not independently cause hypoglycemia and are generally well tolerated, making them suitable for older adults and patients with multiple comorbidities who may not tolerate more potent agents. However, DP4 inhibitors have not demonstrated cardiovascular benefit in outcomes trials and carry some safety signals that limit enthusiasm for their use. A network meta-analysis found associations with increased risk of neuropathy, with an odds ratio of 1.10 and 95% confidence interval of 1.02 to 1.18, and pancreatitis, with an odds ratio of 1.63 and 95% confidence interval of 1.40 to 1.91. Severe and disabling arthralgia has been reported with these agents. In pediatric trials, saxagliptin and linagliptin failed to demonstrate A1C benefit compared with placebo, limiting their role in youth with type 2 diabetes. Let's now address insulin therapy in detail. Insulin remains essential therapy for all individuals with type 1 diabetes and is frequently required in type 2 diabetes when other agents fail to achieve glycemic goals or when marked hyperglycemia is present at diagnosis. The efficacy and safety of insulin therapy depends substantially on appropriate patient education regarding self-monitoring, injection technique, dose adjustment, and hypoglycemia prevention and management. Insulin should be initiated in type 2 diabetes when combination therapy with other agents fails to achieve or maintain glycemic goals, or when individuals present with A1C exceeding 9 to 10%, blood glucose levels exceeding 300 milligrams per deciliter, symptomatic hyperglycemia, or evidence of catabolism such as weight loss. In these circumstances, insulin rapidly addresses the metabolic derangement and may be transitioned to other therapies once glucose toxicity has resolved. For most individuals with type 2 diabetes requiring insulin, initiation with basal insulin added to the existing anti-hyperglycemic regimen represents the preferred approach. The recommended starting dose is 10 units daily, or 0.1 to 0.2 units per kilogram body weight per day, with subsequent titration based on fasting glucose monitoring. A common titration algorithm involves increasing the dose by 2 units every 3 days until the fasting plasma glucose target is achieved without overnight or midday hypoglycemia. The principal action of basal insulin is to restrain hepatic glucose production and limit hyperglycemia overnight and between meals. When adequate basal insulin dosing fails to achieve postprandial glucose control, or when signs of overbasalization emerge, including high bedtime to morning glucose differential of 50 milligrams per deciliter or more, hypoglycemia, or high glucose variability despite escalating doses, addition of prandial insulin should be considered. Prandial insulin is typically initiated at 4 units or 10% of the basal dose with the largest meal, titrated based on postprandial glucose monitoring, and subsequently added to additional meals as needed. For type 1 diabetes, intensive insulin replacement using multiple daily injections or continuous subcutaneous insulin infusion through an insulin pump provides the optimal combination of effectiveness and safety. The landmark diabetes control and complications trial demonstrated that intensive therapy achieving A1C of approximately 7% reduced microvascular complications by roughly 50% compared with conventional therapy, establishing the foundation for current treatment targets. Advanced insulin delivery technologies, including automated insulin delivery systems that integrate continuous glucose monitoring with insulin pumps to automatically adjust basal insulin delivery, should be offered to all individuals with type 1 diabetes and considered for those with type 2 diabetes on intensive insulin regimens. These systems reduce the burden of diabetes self-management while improving time in range and reducing hypoglycemia. Let's conclude Module 3 by discussing comparative safety and treatment selection. The comparative safety profiles of newer diabetes medications inform treatment selection and patient counseling. SGLT2 inhibitors and GLP-1 receptor agonists consistently demonstrate reduced rates of severe hypoglycemia compared with sulfonylurias and insulin, a favorable attribute that makes them particularly appropriate for patients at elevated hypoglycemia risk, including older adults and those with hypoglycemia unawareness. Network meta-analyses comparing glucose-lowering drug classes have characterized their relative safety profiles across multiple outcomes. GLP-1 receptor agonists demonstrate the greatest reductions in major adverse cardiovascular events and stroke, while SGLT2 inhibitors show superior benefits for heart failure hospitalization and kidney outcomes. Both classes are associated with weight loss, contrasting with the weight gain typically seen with insulin and sulfonylurias. Treatment selection should integrate these comparative effectiveness and safety data with individual patient characteristics, recognizing that many patients will benefit from combination therapy addressing multiple therapeutic goals simultaneously. The availability of fixed-dose combinations and simplified regimens may improve adherence and outcomes in patients requiring multiple medications. Welcome to Module 4, Comorbidities and Complications Across the Lifespan. We'll begin by examining the comorbidity burden in type 2 diabetes. The clinical complexity of type 2 diabetes extends far beyond glycemic dysregulation to encompass a constellation of comorbid conditions that collectively determine health outcomes, quality of life, and healthcare utilization. Population-based studies consistently demonstrate that multimorbidity is the rule rather than the exception in diabetes, with the majority of affected individuals managing multiple chronic conditions simultaneously. The most prevalent comorbidities in adults with type 2 diabetes are hypertension, affecting 47 to 72% of patients, hyperlipidemia, present in 60 to 80%, obesity, affecting approximately 45%, chronic kidney disease, present in about 1/3, and depression, affecting roughly 1/4 of the diabetic population. Studies examining multimorbidity patterns reveal that 82% of individuals with type 2 diabetes have at least 2 comorbid conditions, and 31% have 4 or more. The mean number of comorbidities increases with diabetes duration, rising from 1.7 at diagnosis to 3.2 after 10 years of disease. Traditional diabetes-related microvascular complications, retinopathy, nephropathy, and neuropathy occur frequently but represent only part of the overall comorbidity burden. Retinopathy affects approximately 32% of individuals with type 2 diabetes, ischemic heart disease occurs in 14%, and renal disease in 12%, with prevalence increasing substantially over the disease course. Retinopathy prevalence, for example, rises from 4.8% at diagnosis to 41.3% after 10 years. Analysis of comorbidity clustering patterns reveals that hypertension serves as a central node connecting multiple other conditions. The most frequent comorbidity combinations all include hypertension, hypertension with back pain affecting 24% of patients, hypertension with retinopathy at 22%, hypertension with ischemic heart disease at 17%, hypertension with osteoarthritis at 16%, and hypertension with depression at 15%. The co-occurrence of hypertension and hyperlipidemia is particularly common, present in 45% of patients with type 2 diabetes. Now, let's examine the accelerated comorbidity development observed in adolescents with type 2 diabetes. Youth-onset type 2 diabetes represents a particularly aggressive disease phenotype characterized by earlier onset of comorbidities, faster disease progression, and higher rates of complications than either childhood-onset type 1 diabetes or adult-onset type 2 diabetes. This accelerated trajectory has profound implications for lifetime morbidity and mortality, as individuals diagnosed in adolescence face decades of disease exposure during what should be their most productive years. Comorbidities are frequently present at the time of diagnosis in adolescents with type 2 diabetes. Hypertension affects 10 to 19%, microalbuminuria is present in 13 to 27%, and dyslipidemia, the most prevalent and treatment-resistant comorbidity in this population, affects up to 80% of youth at diagnosis. The dyslipidemia of adolescent type 2 diabetes is characterized by low HDL cholesterol in 80.5%, elevated triglycerides in 65.6%, and substantially elevated LDL cholesterol in 4.5%, abnormalities that persist and worsen regardless of treatment approach. The progression of comorbidities in adolescent type 2 diabetes is disturbingly rapid. After 4 to 5 years of disease, hypertension prevalence increases to 34 to 46%, and microalbuminuria to 16 to 39%. Renal disease emerges as the most common and earliest microvascular complication, with higher risk of progression than observed in childhood type 1 diabetes or adult type 2 diabetes. Most children and adolescents who develop type 2 diabetes will have microvascular complications by young adulthood. The pathophysiologic basis for this accelerated disease course appears to involve more severe insulin resistance and faster beta cell function decline than observed in adults. Studies demonstrate that adolescents with type 2 diabetes exhibit 50% higher insulin resistance at baseline than adults matched for weight and BMI, despite similar or lower absolute body mass. Beta cell function declines at a rate of 20 to 35% per year in youth, compared with approximately 7% per year in adults, representing a 2 to 4-fold acceleration in the loss of endogenous insulin secretion. This rapid deterioration explains the high rate of treatment failure and early insulin requirement observed in adolescent type 2 diabetes. Let's now discuss mental health comorbidities in diabetes. Depression and anxiety disorders represent major comorbidities in diabetes that carry implications for self-management, glycemic control, and overall outcomes. Depression affects approximately 26% of adults with type 2 diabetes, making it the fourth most common comorbidity. The relationship between diabetes and depression appears bidirectional, with each condition increasing risk for the other through mechanisms involving chronic stress, inflammation, and health behavior pathways. Young adults with type 2 diabetes face disproportionately high mental health burden. Those diagnosed before age 45 have 3.4 to 4.2 times increased odds of depression, bipolar disorder, anxiety, or stress-related disorders compared with age-matched individuals without diabetes. Among adolescents with type 2 diabetes, 20% have mental health conditions, and 40% of hospitalizations in young people with type 2 diabetes are related to mental health concerns rather than diabetes-specific complications. The relationship between age at diabetes diagnosis and mental health risk demonstrates a clear gradient. Adjusted risk ratios for depression range from 4.4 in those diagnosed at ages 16 to 27 years to 2.5 in those diagnosed at ages 48 to 50 years. While the relative risk diminishes with older age at diagnosis, the absolute prevalence of mental health comorbidities increases with age due to the higher baseline rates of these conditions in older populations. The presence of depression in diabetes is associated with worse glycemic control, reduced medication adherence, higher rates of complications, increased healthcare utilization, and elevated mortality. Integrated care approaches that systematically screen for and treat co-occurring depression alongside diabetes management have demonstrated significant improvements in both glycemic outcomes, with mean A1C reduction of 0.36%, and depressive symptoms. Studies incorporating behavioral activation combined with cognitive behavioral therapy show particularly strong effects on A1C reduction. Now let's examine cardiovascular risk and age-related patterns. Cardiovascular disease represents the leading cause of morbidity and mortality in individuals with diabetes, affecting 32.2% of people with type 2 diabetes globally. The risk is substantially elevated compared with the general population, with type 2 diabetes diagnosis associated with more than double the odds of myocardial infarction, with an odds ratio of 2.13, and heart failure, with an odds ratio of 2.12 compared with matched controls without diabetes. The relationship between age at type 2 diabetes diagnosis and cardiovascular risk demonstrates that earlier onset confers dramatically higher relative risk. Among young adults diagnosed before age 30, 11% already have two or more long-term conditions, including stroke, myocardial infarction, chronic kidney disease, hypertension, and depression, at the time of diabetes diagnosis. A 25% increase in risks of hyperglycemic crises, acute myocardial infarction, stroke, and lower extremity amputation over a 5-year period was most pronounced in people with diabetes aged 18 to 44 years. The adjusted risk ratios for comorbidities show steep gradients by age at diagnosis. For obesity, the adjusted risk ratio is 13.8 for those diagnosed at ages 16 to 27 years versus 5.7 for diagnosis at ages 48 to 50 years. For hypertension, the ratio is 28.9 versus 3.2. For depression, 4.4 versus 2.5. And for anxiety, 4.3 versus 2.2. These findings emphasize that while the absolute burden of multimorbidity increases with age, the relative impact of diabetes on comorbidity risk is greatest when the disease develops early in life. The cardiovascular kidney metabolic syndrome conceptualization recognizes the interconnected pathophysiology of obesity, diabetes, chronic kidney disease, and cardiovascular disease, and emphasizes the need for integrated management approaches addressing multiple risk domains simultaneously. Interdisciplinary care models incorporating representation from cardiology, endocrinology, pharmacy, and nutrition have demonstrated increased use of cardiometabolic therapies and more favorable metabolic risk profiles. Let's conclude Module 4 by examining clinical presentation differences between adolescents and adults. Understanding the distinct clinical features of diabetes in adolescent versus adult populations is essential for accurate diagnosis and appropriate management intensity. Beyond the comorbidity patterns discussed above, fundamental differences in symptom presentation, metabolic phenotype, and disease trajectory distinguish youth onset from adult onset diabetes. Adolescents with type 2 diabetes are frequently asymptomatic at presentation, with only 67% presenting with symptoms and approximately one-third identified through screening of at-risk individuals. When symptoms occur, they may be less pronounced than in type 1 diabetes. Acute presentations differ as well. Diabetic ketoacidosis occurs in only 6 to 11% of adolescent type 2 diabetes cases, and the prevalence appears to have declined over the past 10 to 15 years as awareness and screening have improved. The metabolic phenotype of adolescent type 2 diabetes involves more severe insulin resistance despite similar or lower BMI compared with adults. Adolescents demonstrate 53% higher hepatic and 42% higher peripheral insulin resistance than older adults matched for body fat percentage, race, and sex. Paradoxically, beta cells in adolescents show hyperresponsiveness to stimulation compared with adults, yet this compensatory mechanism fails more rapidly, leading to earlier glycemic deterioration. Obesity is nearly universal in adolescents with type 2 diabetes, with prevalence ranging from 64.5% in Asian populations to 89.9% in European populations, reflecting variable metabolic thresholds across ethnic groups. Family history is particularly prominent, with positive histories in nearly 90% within the first or second generation. A strong female predominance characterizes adolescent type 2 diabetes, with the treatment options for type 2 diabetes in adolescents and youth, or today, cohort being 65% female, a pattern attributed to greater physiologic insulin resistance during puberty in girls than boys. The time to treatment failure is dramatically shorter in adolescence. In the Today study, glycemic failure rate with metformin alone was 52%, compared with 12% in the adult diabetes outcome progression trial, known as ADOPT, despite youth having shorter diabetes duration. This accelerated treatment failure underscores the need for early and aggressive therapeutic intervention in adolescent type 2 diabetes. Welcome to Module 5, Technology Integration in Diabetes Care. We'll begin with a comprehensive look at continuous glucose monitoring. Continuous glucose monitoring has emerged as a transformative technology in diabetes care, providing real-time or near real-time glucose data that enables more informed treatment decisions and tighter glycemic control than traditional fingerstick blood glucose monitoring alone. The American Diabetes Association recommends CGM use at diabetes onset and any time thereafter for adults with diabetes who are on insulin therapy, on non-insulin therapies that can cause hypoglycemia, and on any diabetes treatment where CGM aids in management. Two principal CGM modalities are available: real-time CGM, which provides continuous glucose data with alerts for hypoglycemia and hyperglycemia, and intermittently scanned CGM, also known as flash glucose monitoring, which requires the user to scan the sensor to obtain glucose readings. Both modalities have demonstrated benefits for glycemic control, though real-time CGM with alert functionality may offer advantages for hypoglycemia prevention in individuals with impaired hypoglycemia awareness. The evidence supporting CGM use has expanded considerably in recent years. A systematic review and meta-analysis of 22 randomized controlled trials in type 1 diabetes demonstrated A1C reduction of 0.26%, with a 95% confidence interval of negative 0.37 to negative 0.15% with CGM use. For individuals with type 2 diabetes treated with insulin, both intermittently scanned and real-time CGM result in better overall glucose control as defined by A1C and time in range of 70 to 180 milligrams per deciliter, fewer hyperglycemic and hypoglycemic episodes, and improvements in diabetes distress. The benefits of CGM extend beyond individuals on intensive insulin therapy. Randomized trial data demonstrate that CGM provides benefits in people with type 2 diabetes not using insulin, with greater improvements in A1C, time in range, time below range, and time above range compared with blood glucose monitoring, along with higher user-reported satisfaction. When individuals with type 2 diabetes on basal insulin discontinued CGM use, partial reversal of A1C and time in range improvements occurred, suggesting that sustained CGM use achieves the greatest benefits. Importantly, the benefits of CGM are amplified when combined with diabetes self-management education and support, often abbreviated DSMES, or behavioral interventions. Studies demonstrate that DSMES plus intermittently scanned CGM produces increased time in range, less time above range, and greater A1C reduction compared with DSMES alone. This finding underscores the importance of integrating technology within comprehensive care models rather than deploying devices in isolation. Now let's discuss automated insulin delivery systems. Automated insulin delivery systems represent the most advanced current technology for insulin management, integrating continuous glucose monitoring with insulin pumps to automatically adjust basal insulin delivery based on sensor glucose values. These closed-loop or hybrid closed-loop systems reduce the burden of diabetes self-management while achieving tighter glycemic control with less hypoglycemia than conventional pump therapy or multiple daily injections. The ADA recommends that automated insulin delivery systems be offered to all adults with type 1 diabetes and considered for those with type 2 diabetes on intensive insulin regimens, depending on individual needs and preferences. Multiple systems are now commercially available, differing in their algorithms, user interface, and degree of automation, but all sharing the fundamental approach of adjusting insulin delivery in response to real-time glucose data. Automated insulin delivery systems have demonstrated the ability to help a majority of users meet or approach glycemic goals while decreasing some of the burdens of diabetes management. The technology continues to evolve rapidly, with emerging applications including AID support for individuals who frequently miss meal boluses and use in populations such as those with cystic fibrosis-related diabetes and diabetes during pregnancy. For individuals with type 2 diabetes, continuous subcutaneous insulin infusion, that is, pump therapy without automated adjustment, is associated with small improvements in A1C and fewer hypoglycemic events, suggesting that pumps can be considered for those treated with multiple daily injections who are able to manage the device. Cloud-based access to diabetes data from glucose sensors and insulin delivery devices has enabled virtual care models in which clinicians can review glucose and insulin data remotely, facilitating telehealth visits and remote dose adjustments. Let's now examine telehealth and remote care delivery. The COVID-19 pandemic accelerated adoption of telehealth for diabetes care, and accumulating evidence supports the effectiveness of remote care delivery for glycemic management. A 2025 systematic umbrella review encompassing 30 systematic reviews and meta-analyses found that 28 reviews analyzing A1C reported significant reductions with telehealth interventions, with a meta-analytic estimate from 16 reviews covering 681 unique trials showing mean A1C reduction of 0.37%, with a 95% confidence interval of -0.41 to -0.32%. Telehealth appears to be non-inferior to traditional in-person care for diabetes management, with potential advantages for certain populations, including those who require more frequent interactions, are newly diagnosed, have higher A1C levels, have gestational diabetes, or have comorbid conditions. Interactive strategies that facilitate communication between healthcare professionals and patients, including web-based portals, text messaging, and those incorporating medication adjustment, appear particularly effective. The effectiveness of telehealth extends to diverse populations. A systematic review of telehealth trials aimed at improving A1C among Black and Hispanic adults with type 2 diabetes found a mean A1C reduction of 0.47%, with a 95% confidence interval of -0.65 to -0.28%, demonstrating that telehealth can be effective in reducing health disparities when appropriately designed and supported. However, these successes typically depend on substantial investments in infrastructure, including laptops, mobile phone access and internet access, and targeted support such as digital literacy education and community health workers that are rarely part of routine care. For children and adolescents with type 1 diabetes, telehealth resources can improve diabetes management and address social determinants of health. A randomized trial of monthly telemedicine visits in children aged 1 to 16 years showed improved parental treatment satisfaction and decreased diabetes burden, with significant A1C improvement emerging at 12 to 15 months of follow-up. Now let's explore mobile health applications. Mobile health applications represent an increasingly accessible form of digital support for diabetes self-management, offering features including blood glucose tracking, insulin dose calculation, diet and exercise logging, medication reminders, and educational content. The evidence for app-based interventions has matured considerably, with multiple meta-analyses now characterizing their effectiveness. A meta-analysis of 41 randomized controlled trials found that app-based interventions significantly improved glycemic control, with mean A1C reduction of 0.49%, with a 95% confidence interval of -0.65 to -0.32% compared with standard care. A 2025 systematic review examining component contributions found that mobile applications combined with professional education programs and peer support education produced the largest A1C reductions at 1.98%, while mobile applications alone achieved reductions of approximately 0.30%. The effectiveness of mobile health interventions varies considerably based on user engagement and intervention design. High-intensity coaching within digital interventions produces greater A1C reductions of 0.45% than medium intensity at 0.29% or low intensity at 0.28% coaching. One common feature of effective digital health interventions is the availability of timely and responsive personalized coaching by a dedicated healthcare professional. Individuals with higher baseline A1C of 9% or greater benefit more from smartphone application use than those with lower baseline values. Systematic review evidence indicates that smartphone applications and SMS-based interventions demonstrate effectiveness, while website-based interventions have not consistently shown benefit. Smartphone applications show higher reach compared with SMS and website based interventions, though website based interventions demonstrate higher initial uptake. This pattern suggests that the portability and convenience of smartphone based delivery may support sustained engagement. While digital health technologies offer substantial potential to improve diabetes outcomes, significant concerns exist regarding equitable access and the risk that technology may exacerbate rather than reduce health disparities. This is often referred to as the digital divide. The digital divide encompasses financial barriers, including cost of devices, data plans, and high speed internet, informational barriers such as numeracy, literacy, and digital skills, and technical barriers including interoperability challenges and complex user interfaces that disproportionately affect socioeconomically disadvantaged populations. Effective telehealth design must consider accessibility, affordability, connectivity, trust, and contextual tailoring. Failure to address these factors risks widening existing inequities. The DSMES team should consider characteristics including racial identity, ethnic and cultural background, biological sex and gender identity, age, geographic location, technology access, education, literacy, and numeracy when designing and delivering technology enabled interventions. Successful implementation of digital health interventions in underserved populations typically requires infrastructure support and targeted assistance. Without provision of devices, internet access, and digital literacy education, resources rarely included in routine care, attrition rates are high and benefits are diminished. Community health workers can serve as bridges connecting patients with technology and addressing barriers to engagement. Let's conclude Module 5 by discussing cost effectiveness and implementation considerations. Telehealth appears to be cost effective and is likely to become more economical as technologies mature and automated features reduce clinician time requirements. DSMES, delivered through technology enabled platforms, is associated with lower healthcare costs, and individuals who participate in DSMES have lower Medicare and insurance claim costs. Technology enabled diabetes self management solutions improve outcomes most effectively when they incorporate two-way communication between the person with diabetes and the healthcare team, individualized feedback, use of person generated health data, and education. The integration of technology within comprehensive care models rather than deployment of devices in isolation appears essential for realizing their full potential. Telehealth should complement rather than replace in-person visits for optimal glycemic management, with the choice of delivery modality aligned with individual preferences and circumstances. Use of diabetes technologies warrants broader adoption because they can reduce therapeutic inertia and facilitate timely treatment intensification when glycemic goals are not met. Welcome to Module 6, Interprofessional Collaboration, focusing on the roles of physical therapy, occupational therapy, and nursing. Let's begin with the framework for team-based diabetes care. The complexity of diabetes management, encompassing glycemic control, medication management, lifestyle modification, complication prevention, and psychosocial support, exceeds the capacity of any single healthcare professional and necessitates a collaborative, interprofessional approach. The American Diabetes Association recommends that people with diabetes receive care from a coordinated team that may include diabetes care and education specialists, primary care and subspecialty clinicians, nurses, registered dietitian nutritionists, exercise specialists, pharmacists, dentists, podiatrists, and behavioral health professionals. The chronic care model provides the foundational framework for organizing effective diabetes care delivery, encompassing 6 core elements. Delivery system design, which involves transitioning from reactive to proactive team-based care, self-management support, decision support at the point of care, clinical information systems including patient registries, community resources and policies, and health systems creating a quality-oriented culture. Randomized controlled trials of chronic care model interventions demonstrate that programs incorporating 4 or more of these elements achieve greater improvements in glycemic control than those with fewer elements, with mean A1C reduction of 0.21% and a 95% confidence interval of -0.30 to -0.13. Team composition should be tailored to the specific needs of different patient populations. For adolescents with diabetes, the team should include primary care clinicians, pediatric endocrinologists, diabetes care and education specialists, registered dietitian nutritionists, behavioral health professionals, school nurses, and parents or caregivers, with particular attention to assessing social determinants of health and supporting gradual, developmentally appropriate transfer of self-management responsibilities. For older adults, the team may include geriatric medicine specialists, clinical pharmacists, and importantly, physical and occupational therapists as appropriate based on functional status and independence. For individuals with diabetes-related complications or comorbidities, the team should include relevant specialists along with care coordinators and clinical pharmacists for those with polypharmacy. A systematic review of health professionals' views on multidisciplinary diabetes team care identified 6 factors essential for success: working collaboratively to foster supportive relationships, strong committed organizational and team leadership, diversity and expertise with team composition tailored to local circumstances, shared goals and consistent messaging, clear and open communication, and placing the patient at the center of decision-making. The review also identified a significant gap in shared roles among health professionals, highlighting the need for allied health professionals, including physical therapists, to be integrated into primary healthcare diabetes teams. Now let's examine the role of physical therapy in diabetes care. Physical therapists occupy a critical frontline position in diabetes care given the extraordinary prevalence of diabetes and prediabetes in the populations they serve. Conservative estimates indicate that up to 80% of patients referred for outpatient physical therapy have diabetes or are at significant risk for developing diabetes. This high prevalence provides substantial opportunity for physical therapists to screen for diabetes risk, modify exercise prescriptions for diabetes-related complications, and advocate for physical activity as a cornerstone of diabetes management. The ADA recommends that individuals with diabetes benefit from working with an exercise physiologist, physical therapist, or personal trainer when available and affordable, recognizing the expertise these professionals bring to exercise prescription and physical activity promotion. Physical therapists contribute to diabetes care through systematic screening for risk factors and complications, individualized exercise prescription aligned with current guidelines, modification of interventions based on diabetes-related considerations, and advocacy for regular physical activity in all patient interactions. Current guidelines specify that most adults with type 1 and type 2 diabetes should engage in 150 minutes or more of moderate to vigorous intensity aerobic activity per week, spread over at least 3 days with no more than 2 consecutive days without activity. Shorter durations of minimum 75 minutes per week of vigorous intensity or interval training may suffice for more physically fit individuals. Additionally, adults with diabetes should engage in 2 to 3 sessions per week of resistance exercise on non-consecutive days, and older adults should incorporate flexibility and balance training 2 to 3 times weekly. Physical therapists must assess for disabilities and conditions that might preclude certain exercise types or predispose to injury, including advanced age, limited exercise tolerance, uncontrolled hypertension, claudication, untreated proliferative retinopathy, autonomic neuropathy, diabetic foot disease, and Charcot foot. Recommendations should be tailored to individual needs and capabilities, with incremental exercise prescriptions developed according to both goals and limitations. Plans may require modification over time due to changes in health status, achievement of goals, or if therapeutic response plateaus. Diabetic peripheral neuropathy, affecting up to half of individuals with type 1 or type 2 diabetes, carries particular implications for physical therapy practice. People with lower extremity neuropathy have 3 times the risk of restricted mobility and experience more physical dysfunction than those with diabetes without neuropathy. In the presence of advanced neuropathy, physical therapy consultation is recommended for improvement in balance, gait, posture, and strength, and for consideration of assistive devices. Customized rehabilitation interventions for individuals with diabetes-related disability can recover function, enable safe physical activity, and improve quality of life. Evidence supporting exercise interventions in diabetes is robust. A systematic review and meta-analysis of combined aerobic and resistance exercise in middle-aged and older adults with type 2 diabetes found significant positive effects on cognition, metabolic health including A1C with a standardized mean difference of -0.35, and physical health-related quality of life. The analysis revealed that clinically important effects may occur when combining low to moderate intensity aerobic exercise with progressive intensity resistance training, with total exercise duration of at least 135 minutes per week, including at least 60 minutes of resistance training. A randomized controlled trial of intensive lifestyle intervention combining diet and exercise in older adults with diabetes and comorbidities demonstrated superior outcomes across multiple domains. These included A1C reduction of negative 0.8% versus positive 0.1%, body weight reduction of negative 8.4 kilograms versus negative zero point 0.3 kilograms, improved physical performance test scores of positive 2.9 versus negative zero point 0.1, improved peak oxygen consumption of positive 2.2 versus negative 1.2 milliliters per kilogram per minute, as well as improvements in strength, gait, and quality of life. These comprehensive benefits illustrate the transformative potential of exercise based interventions for older adults with diabetes. Now, let's discuss the role of occupational therapy in diabetes care. Occupational therapy brings unique value to diabetes care teams through its focus on enabling individuals to participate in meaningful daily activities and routines. Occupational therapists evaluate multiple levels of influence on diabetes self management, address personal and environmental barriers to well being, and support patients in developing the complex competencies required for successful self management. The strongest evidence for occupational therapy effectiveness in diabetes comes from the resilient, empowered, active living with diabetes or real diabetes randomized controlled trial. This study enrolled 81 young adults with a mean age of 22.6 years with type 1 or type 2 diabetes and baseline A1C of 10.8% and randomized them to a manualized occupational therapy intervention or attention control. Intent to treat analyses demonstrated that intervention participants achieved significant improvements in A1C of negative 0.57% versus positive 0.36% with a p-value of 0.01, diabetes-related quality of life of positive zero point 0.7 versus positive 0.15 with a p-value of 0.54, and habit strength for blood glucose checking of positive 3.9 versus positive 1.7 with a p-value of 0.05. Notably, the real diabetes intervention was effective across diverse subgroups, with no significant effect modification by sex, ethnicity, diabetes type, recruitment site, or socioeconomic status. This broad applicability suggests that the intervention approach focusing on integrating diabetes management into daily routines, habit formation for self-care behaviors, addressing barriers, and building problem-solving and coping skills addresses fundamental challenges common across the heterogeneous diabetes population. A subsequent trial evaluated telehealth delivery of occupational therapy, called REAL-T, among 209 young adults with type 1 diabetes. While glycemic outcomes did not improve with telehealth occupational therapy, participants demonstrated improved diabetes-related quality of life with a least squares mean of 0.67 and p-value of 0.045, and reduced diabetes distress with a least squares mean of negative 0.36 and p-value of 0.01. These findings suggest that occupational therapy may be particularly beneficial for addressing psychosocial outcomes in young adults, even when delivered remotely, though in-person delivery may be needed to achieve glycemic benefits. Additional trial evidence supports occupational therapy effectiveness in adults with type 2 diabetes. A randomized trial of a 10-week occupational therapy diabetes self-management intervention comprising 4 group visits and 6 individualized sessions demonstrated significant improvements in A1C, self-management behaviors, self-efficacy, and satisfaction with daily routines compared with control. The authors concluded that inclusion of occupational therapy in diabetes care plans can improve health outcomes by promoting routine participation in self-management activities. For adolescents with diabetes, occupational therapy interventions aim to facilitate autonomy and developmentally appropriate transfer of self-management responsibilities. This focus on supporting the transition from parent-managed to self-managed diabetes is particularly relevant during adolescence, when developmental tasks of identity formation and independence intersect with the demands of chronic disease management. Now let's examine nursing roles and insulin management. Nurses across practice settings increasingly encounter patients requiring diabetes management, and their competence in insulin therapy carries direct implications for patient safety and outcomes. Nurse led models of care for insulin initiation have demonstrated feasibility and effectiveness in primary care settings, where they can overcome clinical inertia and support patients in making timely transitions to insulin when indicated. Multifaceted educational interventions combining multiple strategies are most effective for improving nurses' adherence to diabetes clinical practice guidelines. A systematic review found that comprehensive educational approaches improved clinical outcomes, including A1C, blood pressure, and lipid profiles, while enhancing nurses' adherence to guidelines. The most effective implementation strategies include health professional development, reminders for clinicians, patient mediated interventions, health information systems, and role expansion. Interactive online educational modules have demonstrated significant impact on insulin administration safety. A pediatric study found that a mandatory online module teaching insulin pharmacokinetics, dosing, and administration through interactive cases reduced the insulin error rate from 14.8% to 1.7% with a p-value less than 0.001, and hypoglycemia rate from 5.9% to 3.4% with a p-value of 0.001. Improvements occurred across multiple domains, including correct insulin dosing and type, timing of administration, and blood glucose monitoring. Nurse led online education programs have also demonstrated effectiveness for patient outcomes. A quasi experimental trial of nurse led online education for patients initiating basal insulin found that intervention participants achieved significantly better fasting blood glucose compliance and A1C at 3 and 6 months compared with routine physician led follow up, along with improved attitudes toward insulin therapy. For practical insulin management, nurses should understand the basic principles of insulin initiation and titration. Beginning with a fixed dose, typically 10 units daily, and increasing by 2 units twice weekly is a simple approach that, while potentially taking months to reach fasting glucose targets, provides a systematic framework appropriate for primary care settings. Standardized insulin order sets and clinical decision support tools significantly improve glycemic control, reduce errors, and enhance nursing satisfaction. Proper injection technique represents another critical nursing competency. The Fitter Forward expert recommendations provide updated, evidence-based guidance on insulin injection education, addressing the reality that many patients experience suboptimal outcomes due to inadequate injection technique and training. Nurses require comprehensive training in injection technique to effectively educate patients and prevent complications such as lipohypertrophy that can impair insulin absorption. Now let's discuss quality improvement strategies for diabetes care. The ADA recommends that health systems use proven quality improvement methods to translate standards of care recommendations into routine practice. A successful quality improvement team should include a clinical champion, administrative leader, quality improvement specialist, and an individual living with or affected by diabetes. A Cochrane systematic review of quality improvement strategies for diabetes care identified that multi-component QI programs may achieve meaningful population-level improvements across multiple outcomes. The most effective QI strategy combinations differed by outcome but consistently included 4 key elements: case management, team changes, patient education, and promotion of self-management. For A1C reduction when baseline is elevated at 8.3%, the combination of case management, patient education, and electronic patient registry achieved the greatest improvement of 0.62% reduction. Quality improvement methods have been documented to improve diabetes technology uptake, increase screening for psychosocial needs, and reduce inequities in access to diabetes technologies. Using patient registries and electronic health records, health systems can evaluate care quality, benchmark metrics against targets, and perform intervention cycles as part of continuous improvement strategies. Let's conclude Module 6 by identifying patient populations benefiting most from allied health integration. While all individuals with diabetes may benefit from interprofessional team care, certain populations derive particular value from physical and occupational therapy integration based on clinical characteristics and functional needs. Older adults represent the population with the strongest guideline-based recommendation for physical and occupational therapy integration, with the ADA explicitly recommending these professionals as team members based on functional status and independence needs. Diabetes is associated with 50 to 80% increased disability risk, with lower body functional limitation being most prevalent. Falls occur in 25% of individuals with diabetes, compared with 18.2% without diabetes, and physical therapy interventions may reduce fall risk factors and potentially fall and fracture rates. Young adults with poor glycemic control and psychosocial distress demonstrate substantial benefit from occupational therapy, as evidenced by the real diabetes trial showing A1C improvement of 0.57%, along with improved quality of life in this population. The intervention's effectiveness across ethnic groups and socioeconomic strata makes it particularly valuable for addressing health disparities. Individuals with diabetes-related complications, particularly peripheral neuropathy affecting mobility and balance, require physical therapy assessment and intervention. Those with lower extremity neuropathy experience threefold increased mobility restriction and benefit from targeted interventions addressing balance, gait, and strength. Adolescents developing self-management autonomy benefit from occupational therapy's focus on supporting developmentally appropriate transfer of diabetes management responsibilities from caregivers. The unique challenges of adolescence, identity formation, peer relationships, and emerging independence intersect with chronic disease demands in ways that occupational therapy is well positioned to address. Welcome to Module 7, Case Studies in Diabetes Management. Let's begin with an introduction to case-based learning. The following case studies are designed to illustrate the application of evidence-based principles presented throughout this course to realistic clinical scenarios. Each case integrates multiple concepts from the preceding modules and challenges learners to synthesize diagnostic reasoning, therapeutic decision-making, and interprofessional collaboration skills. The cases represent common clinical presentations encountered by physical therapists, occupational therapists, nurses, and other allied health professionals in diverse practice settings. Let's begin with Case Study 1, Distinguishing Diabetes Type in an Adult with Atypical Presentation. Marcus Williams is a 38-year-old African-American man referred to outpatient physical therapy for chronic low back pain with radicular symptoms. During the initial evaluation, Mr. Williams mentions that he was recently diagnosed with diabetes by his primary care physician approximately 3 months ago and started on metformin 500 milligrams twice daily. He expresses frustration that his blood sugars remain elevated despite taking his medication consistently and trying to eat better. His medical history includes vitiligo diagnosed at age 25 affecting his hands and face, a new diagnosis of type 2 diabetes 3 months ago, hypertension diagnosed 2 years ago, controlled on lisinopril 10 milligrams daily, and hypothyroidism diagnosed at age 32, currently managed with levothyroxine 75 micrograms daily. His family history reveals that his mother has type 2 diabetes diagnosed at age 58, managed with oral medications. His father has hypertension and hyperlipidemia, his maternal aunt has type 1 diabetes diagnosed at age 42, and his sister has Hashimoto's thyroiditis. Socially, Mr. Williams is a high school physical education teacher and basketball coach who is physically active and exercises 4 to 5 times per week. He is a non-smoker with occasional alcohol use and is married with 2 children. On physical examination, Mr. Williams measures 5 feet 11 inches tall and weighs 172 pounds, giving him a BMI of 24.0 kilograms per meter squared. His blood pressure is 128/78. Notably, no acanthosis nigricans is observed, and vitiligo patches are visible on his dorsal hands and periorbital region. Laboratory values from the referring physician obtained 2 weeks ago show hemoglobin A1C of 9.2%, fasting plasma glucose of 198 milligrams per deciliter, and a random glucose obtained today, 2 hours postprandially, of 267 milligrams per deciliter. During the physical therapy evaluation, Mr. Williams reports unintentional weight loss of approximately 12 pounds over the past 4 months despite no deliberate dietary changes. He also notes increased thirst and urinary frequency that he attributed to drinking more water because of exercise. Let's analyze this case by applying the AABPCC framework to systematically evaluate the likelihood of type 1 versus type 2 diabetes. Regarding age, at 38 years, Mr. Williams falls near the threshold where age becomes less discriminating. While age below 35 years favors type 1 diabetes, the distinction becomes less clear in the late 30s to early 40s. Importantly, up to 40% of adults with type 1 diabetes are diagnosed after age 30, and many are initially misclassified as having type 2 diabetes. His age does not definitively favor either diagnosis, but does not exclude type 1 diabetes. Regarding autoimmunity, this criterion strongly favors type 1 diabetes in Mr. Williams. He has a personal history of two autoimmune conditions: vitiligo, an autoimmune skin disorder, and hypothyroidism, likely autoimmune thyroiditis given the family history of Hashimoto's disease in his sister. His family history includes a maternal aunt with type 1 diabetes diagnosed in adulthood and a sister with Hashimoto's thyroiditis, indicating familial clustering of autoimmune disorders. The presence of multiple personal autoimmune conditions substantially increases the probability of autoimmune diabetes. Continuing with the AABBCC framework regarding body habitus, with a BMI of 24.0 kilograms per meter squared, Mr. Williams is in the normal weight range, which favors type 1 diabetes. The majority of individuals with type 2 diabetes have BMI at or above 25 kilograms per meter squared, though exceptions exist, particularly in certain ethnic populations. His lean body habitus in the context of other clinical features is concerning for type 1 diabetes. Regarding family background, the history is mixed. His mother has type 2 diabetes, which is common given its high prevalence and could occur coincidentally in a family with autoimmune disease. However, his maternal aunt's type 1 diabetes diagnosed at age 42 represents a more specific risk factor. First-degree relatives of individuals with type 1 diabetes carry approximately 15-fold increased risk compared with the general population, and this risk extends to second-degree relatives as well. Regarding control, Mr. Williams has been unable to achieve glycemic control on metformin monotherapy, with A1C of 9.2% after 3 months of treatment. While many patients with type 2 diabetes require combination therapy, the inability to achieve goals on non-insulin therapies, particularly in combination with other suggestive features, raises concern for inadequate endogenous insulin production consistent with type 1 diabetes. Regarding comorbidities, while Mr. Williams does not have immune checkpoint inhibitor exposure or other specific comorbidities strongly associated with type 1 diabetes, his autoimmune disease cluster of vitiligo and hypothyroidism represents a significant comorbidity pattern favoring autoimmune diabetes. Based on this analysis, the physical therapist should communicate concerns to the referring physician and recommend the following laboratory evaluation. First, measurement of islet autoantibodies is essential. GAD65 antibodies should be measured initially given their superior sensitivity for detecting autoimmune diabetes in adults. If GAD65 is negative, additional testing for IA2 and ZNT8 antibodies should be performed, as some individuals are positive for these antibodies while GAD65 negative. The presence of even one autoantibody in the context of hyperglycemia and clinical features suggestive of type 1 diabetes would support reclassification. Second, C-peptide measurement would provide information about endogenous insulin secretion. A random C-peptide obtained within 5 hours of eating, with concurrent glucose measurement, can replace formal stimulated testing. A stimulated C-peptide below 200 picomoles per liter suggests severe insulin deficiency consistent with type 1 diabetes, while detectable or elevated C-peptide supports type 2 diabetes with preserved endogenous secretion. If Mr. Williams has type 1 diabetes or latent autoimmune diabetes in adults, continued treatment with metformin alone is inadequate and potentially dangerous. Type 1 diabetes is characterized by progressive beta cell destruction leading to absolute insulin deficiency. Without insulin therapy, he is at risk for diabetic ketoacidosis, which can be life-threatening. His symptoms of weight loss, polyuria, and polydipsia, despite oral medication, are concerning for ongoing metabolic decompensation. LADA, a form of autoimmune diabetes with slower progression than classic type 1 diabetes, may initially respond partially to oral agents but typically requires insulin within months to a few years of diagnosis. Early initiation of insulin in LADA may help preserve residual beta cell function longer than delayed insulin initiation. The physical therapist's role in this case is critical. Physical therapists are frontline healthcare professionals who often have extended contact time with patients and opportunity to identify concerning clinical patterns. In this case, the physical therapist's systematic review of medical history, observation of clinical features such as lean body habitus, absence of acanthosis nigricans, and presence of vitiligo, and attentive listening to patient-reported symptoms revealed a clinical picture inconsistent with the working diagnosis. The physical therapist's responsibilities include documenting the clinical findings and concerns in the medical record, communicating directly with the referring physician about the atypical presentation, recommending specific diagnostic testing including autoantibodies and C-peptide, ensuring the patient understands the importance of follow-up for diabetes classification, and modifying the physical therapy plan as appropriate pending diagnostic clarification. Given that up to 80% of patients in outpatient physical therapy have diabetes or diabetes risk factors, physical therapists must maintain vigilance for presentations that warrant additional medical evaluation. This case illustrates how interprofessional communication can identify potential diagnostic errors and improve patient safety. Here is the clinical outcome for Mr. Williams. Following communication from the physical therapist, Mr. Williams' primary care physician ordered islet autoantibody testing and C-peptide measurement. Results revealed positive GAD65 antibodies with a titer of 142 units per milliliter, compared to a reference range of less than 5 units per milliliter, and low C-peptide of 0.4 nanograms per milliliter, with a reference range of 0.8 to 3.1 nanograms per milliliter, confirming the diagnosis of autoimmune diabetes consistent with LADA. His diagnosis was reclassified, metformin was continued, and basal insulin was initiated at 10 units daily with titration instructions. At 3-month follow-up, his A1C had improved to 7.4% with no episodes of diabetic ketoacidosis. The key learning points from this case include the traditional dichotomy of type 1 diabetes as a childhood disease and type 2 diabetes as an adult disease is outdated, as both types can occur at any age. The AAB-BCC framework provides a systematic approach to evaluating clinical features when diabetes classification is uncertain. Personal and family history of autoimmune conditions significantly increases the probability of autoimmune diabetes. Up to 40% of adults with type 1 diabetes are initially misdiagnosed as having type 2 diabetes. Allied health professionals play an important role in identifying atypical presentations and advocating for appropriate diagnostic evaluation. And misclassification of diabetes type can lead to inadequate treatment and risk of serious complications, including diabetic ketoacidosis. Now let's examine Case Study 2, Pharmacologic Management Selection based on Cardiorenal Risk Profile. Dorothy Chen is a 62-year-old Asian American woman with type 2 diabetes of 8 years duration who presents to the endocrinology clinic for routine follow-up. She has been managed by her primary care physician with metformin, 1,000 milligrams twice daily, and glipizide, 10 milligrams twice daily. Her most recent hemoglobin A1C is 8.1%, and she has been advised that her diabetes medications need adjustment. The diabetes care nurse is conducting the pre-visit assessment and medication reconciliation. Mrs. Chen expresses concern about adding more medications, but states she is motivated to improve her diabetes control because her younger brother recently had a heart attack at age 58, and her mother died of kidney failure related to diabetes. Her medical history includes type 2 diabetes mellitus, diagnosed at age 54. Hypertension for 15 years on amlodipine 10 milligrams and losartan 100 milligrams daily. Hyperlipidemia on atorvastatin 40 milligrams daily. Obesity with a BMI of 31.2 kilograms per meter squared. Osteoarthritis of bilateral knees. History of recurrent urinary tract infections occurring 2 to 3 per year. And coronary artery disease with 70% stenosis of the left anterior descending artery on cardiac catheterization 2 years ago. Managed medically without stent placement. Mrs. Chen's family history is notable for her mother having type 2 diabetes and end-stage renal disease requiring dialysis before dying at age 71, her father having type 2 diabetes and stroke at age 68, and her brother having a myocardial infarction at age 58. Her current medications include metformin 1,000 milligrams twice daily, glipizide 10 milligrams twice daily, amlodipine 10 milligrams daily, losartan 100 milligrams daily, atorvastatin 40 milligrams daily, aspirin 81 milligrams daily, and a calcium and vitamin D supplement. Her laboratory values show hemoglobin A1C of 8.1%. fasting glucose of 156 milligrams per deciliter, creatinine of 1.4 milligrams per deciliter, estimated GFR of 52 milliliters per minute per 1.73 meters squared, indicating CKD stage 3A. Urine albumin to creatinine ratio of 186 milligrams per gram, indicating moderately increased albuminuria. Cholesterol of 78 milligrams per deciliter. Triglycerides of 188 milligrams per deciliter. An HDL cholesterol of 42 milligrams per deciliter. Her vital signs show blood pressure of 138/82, heart rate of 72 beats per minute, weight of 176 pounds or 80 kilograms, height of 5 feet 4 inches or 163 centimeters, and BMI of 30.2 kilograms per meter squared. Let's perform a cardiorenal risk assessment for Mrs. Chen. She presents with multiple high-risk features that profoundly influence medication selection beyond glycemic considerations. Her cardiovascular disease risk factors include established atherosclerotic cardiovascular disease with documented 70% LAD stenosis, a strong family history of premature cardiovascular events with her brother's MI at age 58 and father's stroke, hypertension with current blood pressure above target, dyslipidemia with low HDL and elevated triglycerides despite statin therapy, obesity with BMI of 30. 2 kilograms per meter squared, and type 2 diabetes itself, which doubles the risk of myocardial infarction and heart failure. Her chronic kidney disease indicators include eGFR of 52 milliliters per minute per 1.73 meters squared, representing CKD stage 3A, moderately increased albuminuria with UACR of 186 milligrams per gram, a family history of diabetic nephropathy progressing to end-stage renal disease, and 8 years of diabetes duration with evidence of microvascular disease. The combination of reduced eGFR and albuminuria places Mrs. Chen at high risk for CKD progression. Current guidelines from the American Diabetes Association, American Association of Clinical Endocrinology, and American College of Physicians uniformly recommend that individuals with type 2 diabetes and established atherosclerotic cardiovascular disease or chronic kidney disease receive either an SGLT2 inhibitor or GLP-1 receptor agonist with demonstrated cardiorenal benefit, independent of baseline A1C and independent of metformin use. For Mrs. Chen specifically, an SGLT2 inhibitor is the preferred first addition based on her clinical profile. The rationale includes documented cardiovascular disease, where SGLT2 inhibitors reduce hospitalization for heart failure and have favorable effects on ASCVD outcomes. Chronic kidney disease with albuminuria, where SGLT2 inhibitors have demonstrated renal protective effects independent of glucose lowering, with reductions in sustained eGFR decline, end-stage kidney disease, and renal death. And the ADA-KD-IGO consensus specifically recommending SGLT2 inhibitor therapy for patients with type 2 diabetes and CKD regardless of glycemic control. The most appropriate agents would be empagliflozin, dapagliflozin, or canagliflozin, all of which have demonstrated cardiovascular and renal benefits in dedicated outcomes trials. Her eGFR of 52 milliliters per minute per 1.73 meters squared is well above the thresholds for SGLT2 inhibitor initiation, which are generally 20 to 25 milliliters per minute depending on the specific agent and indication. A GLP-1 receptor agonist with proven cardiovascular benefit, such as liraglutide, semaglutide, or dulaglutide, should also be strongly considered, either as an alternative if the SGLT2 inhibitor is not tolerated, or as an addition given her multiple risk factors. GLP-1 receptor agonists have demonstrated reductions in major adverse cardiovascular events, including myocardial infarction and stroke, and would also provide substantial weight loss benefit given her obesity. The ADAE-ASD consensus and other guidelines support combination therapy with both an SGLT2 inhibitor and a GLP-1 receptor agonist in high-risk individuals like Mrs. Chen, as the mechanisms are complementary and benefits may be additive. The expected benefits of SGLT2 inhibitor therapy for Mrs. Chen include cardiovascular protection with reduced hospitalization for heart failure and favorable effects on atherosclerotic events, renal protection with slowed CKD progression, which is critical given her family history of diabetic nephropathy requiring dialysis. modest A1C reduction of 0.5 to 0.8%, weight loss of 2 to 3 kilograms, and blood pressure reduction of 3 to 5 millimeters of mercury systolic, noting that her current BP remains above target. The potential risks and considerations for Mrs. Chen require attention. Genital mycotic infections affect up to 10% of women and are the most common adverse effect. Mrs. Chen should be counseled about symptoms and preventive hygiene measures. Her history of recurrent UTIs warrants discussion, though meta-analyses suggest SGLT2 inhibitors do not increase bacterial UTI risk. Diabetic ketoacidosis is rare, occurring in less than 0.1% of patients, but can occur even at modest glucose levels. She should be educated about sick day rules and when to hold the medication. Volume depletion is a consideration given her concurrent antihypertensive therapy. Monitoring for orthostatic symptoms is appropriate. With her eGFR of 52, the glucose-lowering effect will be somewhat attenuated, but cardiorenal benefits persist. Regarding management of her current sulfonylurea, glipizide should be discontinued or substantially reduced when adding the SGLT2 inhibitor for several reasons. First, hypoglycemia risk increases when sulfonylureas are combined with other glucose-lowering agents. Mrs. Chen is already on maximum dose glipizide, and adding an SGLT2 inhibitor will further lower glucose. Second, SGLT2 inhibitors and GLP-1 receptor agonists do not independently cause hypoglycemia when used as monotherapy or with metformin, but this protection is negated when combined with sulfonylureas. Third, sulfonylureas have not demonstrated cardiovascular benefit and are associated with weight gain, whereas the SGLT2 inhibitor provides weight loss. The recommended approach is to reduce glipizide to 5 milligrams twice daily, or discontinue entirely when initiating the SGLT2 inhibitor, with glucose monitoring to guide further adjustment. The diabetes care nurse should provide comprehensive education for Mrs. Chen, covering several key areas. The mechanism and expectations should be explained. The medication works by causing the kidneys to excrete excess glucose in the urine. This is the intended effect, not a problem. Mrs. Chen may notice increased urination and sweeter-smelling urine initially. Cardiovascular and kidney benefits should be emphasized. This medication has been shown to protect the heart and kidneys beyond its effect on blood sugar. Given her heart condition and kidney function, these protective effects are a primary reason for prescribing it, as important as glucose control. Genital infection prevention should be addressed. The extra sugar in urine can increase risk of yeast infections. Preventive measures include staying well hydrated, maintaining good genital hygiene, wearing breathable cotton underwear, and recognizing symptoms early so treatment can begin promptly. Sick day rules are critical. If Mrs. Chen becomes ill with vomiting, diarrhea, fever, or significantly reduced food intake, she should hold the SGLT2 inhibitor until she is eating and drinking normally. She should seek medical attention if she feels very unwell, has persistent vomiting, or notices fruity-smelling breath. Hydration guidance, medication timing, and hypoglycemia awareness should also be covered, including taking the medication in the morning to minimize nighttime urination. The key learning points from this case include: contemporary diabetes management prioritizes cardiorenal protection alongside glycemic control, particularly in high-risk individuals. SGLT2 inhibitors and GLP-1 receptor agonists with proven cardiovascular and/or renal benefits should be prescribed for patients with established ASCVD, heart failure, or CKD regardless of A1C level. SGLT2 inhibitors are particularly beneficial in patients with CKD and albuminuria, with renal protective effects independent of glucose lowering. Sulfonylureas increase hypoglycemia risk and should generally be reduced or discontinued when adding SGLT2 inhibitors or GLP-1 receptor agonists. And nurses play a critical role in patient education regarding new diabetes medications, including mechanism, benefits, potential side effects, and sick day management. Now let's examine Case Study 3, Interprofessional Team-Based Care for an Adolescent with Type 2 Diabetes. Jasmine Rodriguez is a 15-year-old Hispanic female referred to a pediatric diabetes specialty clinic after her primary care physician identified elevated blood glucose during a routine sports physical. She was planning to try out for the junior varsity volleyball team but has been feeling more tired than usual over the past few months. Initial laboratory findings from her primary care physician showed a random plasma glucose of 243 milligrams per deciliter, hemoglobin A1C of 8.9%, and repeat fasting plasma glucose of 168 milligrams per deciliter. In the diabetes specialty clinic evaluation, Jasmine reports several months of increased thirst and urinary frequency, which she attributed to hot weather and drinking more sports drinks. She has experienced increased appetite, but denies significant weight loss. She notes feeling tired and having difficulty concentrating in school. She denies any history of diabetic ketoacidosis symptoms such as nausea, vomiting, or abdominal pain. Her medical history includes obesity since age 8 and acanthosis nigricans noted on prior physical examinations. She had menarche at age 11 and has no prior hospitalizations. Jasmine's family history reveals that her mother has type 2 diabetes diagnosed at age 38 and is on metformin. Her father has obesity, prediabetes, and hypertension. Her maternal grandmother has type 2 diabetes and is on insulin. Her maternal grandfather had type 2 diabetes and died of a heart attack at age 62, and her two younger siblings both have obesity. Her social history indicates she is a 10th grade student whose grades have declined from B's to C's over the past semester. She lives with both parents and two younger siblings. She has limited physical activity outside of occasional volleyball practice. Her diet involves frequently skipping breakfast, eating school lunch, having a large dinner, and frequent snacking on chips and soda. She denies tobacco, alcohol, or drug use. Her mother works 2 jobs and her father works an evening shift. Her review of systems reveals frequent headaches, occasional blurred vision, urination 3 to 4 times daily during school but not at night, and she reports feeling down and stressed about school and family responsibilities. She also cares for her younger siblings after school until her parents return from work. Physical examination reveals a height of 5 feet 5 inches or 165 centimeters, weight of 198 pounds or 90 kilograms, and BMI of 32.9 kilograms per meter squared, which is above the 99th percentile for age. Her blood pressure is 128/82, which is elevated for age, and heart rate is 88 beats per minute. Acanthosis nigricans is prominent on her posterior neck and in her axillae. Dilated fundoscopic exam shows no diabetic retinopathy. Monofilament sensation is intact in both feet bilaterally. Her sexual maturity rating is Tanner stage 4. Laboratory results from the specialty clinic show hemoglobin A1C of 8.9%, fasting glucose of 172 milligrams per deciliter, fasting insulin of 38 milli-international units per liter, which is elevated, C-peptide of 4.2 nanograms per milliliter, which is elevated, indicating insulin resistance, negative GAD65 antibodies, negative IA2 antibodies, total cholesterol of 198 milligrams per deciliter, C-liter LDL of 128 milligrams per deciliter, HDL of 36 milligrams per deciliter, triglycerides of 224 milligrams per deciliter, AST of 42 units per liter, which is mildly elevated, LT of 58 units per liter, which is mildly elevated, and urine albumin to creatinine ratio of 45 milligrams per gram, which is mildly elevated. Let's analyze the confirmation of type 2 diabetes in Jasmine. Her presentation is consistent with type 2 diabetes rather than type 1 diabetes based on multiple clinical features. Clinical features supporting type 2 diabetes include obesity with BMI at the 99th percentile, which is the most prevalent risk factor for youth-onset type 2 diabetes. Acanthosis nigricans indicating insulin resistance, which is present in approximately 86% of adolescents with type 2 diabetes. Presentation after puberty at Tanner stage 4. Consistent with the typical timing of youth-onset type 2 diabetes at mid-puberty when physiologic insulin resistance peaks. Absence of diabetic ketoacidosis, as only 6 to 11% of adolescents with type 2 diabetes present with DKA compared with approximately 30% of children with type 1 diabetes. Strong family history with both parents and maternal grandparents affected, representing the positive family histories found in nearly 90% of adolescents with type 2 diabetes, and Hispanic ethnicity as a high-risk ethnic group disproportionately affected by youth-onset type 2 diabetes. Laboratory confirmation includes negative islet autoantibodies, with both GAD65 and IA2 negative, effectively excluding autoimmune type 1 diabetes, elevated C peptide of 4.2 nanograms per milliliter, indicating substantial endogenous insulin production with insulin resistance rather than deficiency, and elevated fasting insulin of 38 milli-international units per liter, further supporting insulin resistance as the predominant pathophysiology. Jasmine presents with multiple comorbidities at the time of diabetes diagnosis, illustrating the accelerated comorbidity development characteristic of adolescent type 2 diabetes. Dyslipidemia is the most prevalent and treatment-resistant comorbidity in adolescent type 2 diabetes. Jasmine demonstrates low HDL cholesterol of 36 milligrams per deciliter, which is present in 80.5% of adolescents with type 2 diabetes. Elevated triglycerides of 224 milligrams per deciliter, present in 65.6%, and elevated LDL cholesterol of 128 milligrams per deciliter. These lipid abnormalities persist and worsen regardless of treatment approach. Hypertension with blood pressure of 128/82 exceeds the 90th percentile for her age, sex, and height. Hypertension is present in 10 to 19% of adolescents with type 2 diabetes at diagnosis and progresses to affect 34 to 46% by 4 to 5 years. Nephropathy with UAC-R of 45 milligrams per gram indicates early diabetic kidney disease, which is the most common and earliest microvascular complication in adolescent type 2 diabetes, with higher progression risk than in childhood type 1 diabetes or adult type 2 diabetes. Non-alcoholic fatty liver disease is suggested by elevated transaminases with AST of 42 and ALT of 58, which is common in adolescents with obesity and type 2 diabetes. Obesity with BMI of 32.9 kilograms per meter squared at the 99th percentile is nearly universal in adolescents with type 2 diabetes. Comparison to adult-onset type 2 diabetes reveals that Jasmine's presentation illustrates the more severe phenotype of youth-onset disease. Adults with type 2 diabetes typically develop these comorbidities over years to decades. Jasmine presents with multiple complications at the time of initial diagnosis. The rate of beta cell function decline in adolescents, which is 20 to 35% per year, is 2 to 4 times faster than in adults at approximately 7% per year, predicting accelerated treatment failure and earlier need for insulin. Studies demonstrate that adolescents with type 2 diabetes exhibit 50% higher insulin resistance at baseline than adults with similar BMI. Jasmine's care requires a coordinated interprofessional team, as recommended by the ADA for adolescents with diabetes. The team should include the following members with specific roles. The pediatric endocrinologist serves as the medical lead responsible for diagnosis confirmation, medication management, and oversight of complication screening. Initial pharmacotherapy will likely include metformin, with consideration of early addition of GLP-1 receptor agonist given the comorbidity burden. The Diabetes Care and Education Specialist provides diabetes self-management education including blood glucose monitoring, medication administration, recognition of hyper and hypoglycemia, and sick day management. Education must be developmentally appropriate and account for Jasmine's school schedule and caregiving responsibilities. The registered dietitian nutritionist develops an individualized nutrition plan addressing the family's food access, cultural preferences, and Jasmine's school and home eating patterns. Given the socioeconomic context with the mother working 2 jobs, practical, affordable meal planning is essential. Continuing with the interprofessional team, the behavioral health professional addresses the psychosocial concerns evident in Jasmine's presentation. Her declining grades, reported feelings of being down and stressed, and caregiver burden from caring for siblings warrant mental health screening and support. Young adults with type 2 diabetes have 3.4 to 4.2 times increased odds of depression and anxiety. The school nurse ensures safe diabetes management at school, including permission for blood glucose monitoring, bathroom access, and management of hyper and hypoglycemia during the school day. The exercise specialist or physical therapist can help Jasmine safely increase physical activity, potentially incorporating volleyball if she wishes to continue, and developing a sustainable exercise plan addressing the ADA recommendation that adolescents engage in 60 minutes or more of moderate to vigorous aerobic activity daily. The social services professional addresses social determinants of health, including food insecurity, parental work schedules affecting supervision and meal preparation, and potential need for community resources. The parents and caregivers are essential team members, though engagement may be challenging given their work schedules. Care coordination must accommodate these constraints while supporting gradual, developmentally appropriate transfer of self management to Jasmine. Addressing the psychosocial and social determinants of health is critical for Jasmine. Mental health screening should include formal screening for depression and diabetes distress, using validated instruments such as the Patient Health Questionnaire for adolescents. Jasmine's declining grades, fatigue, reported feelings of being down, and family stress warrant comprehensive assessment. 20% of adolescents with type 2 diabetes have mental health conditions, and 40% of hospitalizations in this population are related to mental health. Family dynamics and caregiver burden require attention, as Jasmine provides substantial caregiving for younger siblings, which may compete with time and energy for diabetes self-management. This responsibility also limits her availability for physical activity and structured diabetes education programs. Socioeconomic barriers include the mother working 2 jobs and father on evening shift, suggesting potential financial strain and limited parental availability. Food access may be challenging, and practical, affordable nutrition recommendations are essential. Cultural considerations include Hispanic and Latino cultural factors that may influence health beliefs, family roles, and dietary preferences. Culturally concordant education materials and, where possible, Spanish-speaking team members will enhance engagement. School support should include a 504 plan or individualized health plan, ensuring Jasmine's right to manage her diabetes at school, including blood glucose monitoring, access to snacks, bathroom privileges, and accommodations for medical appointments. The key learning points from this case include adolescent type 2 diabetes represents a more severe phenotype than adult onset disease, with faster beta cell decline, earlier and more prevalent comorbidities, and higher treatment failure rates. Dyslipidemia is the most prevalent comorbidity at diagnosis in adolescents with type 2 diabetes, affecting up to 80% of youth. Negative autoantibodies and elevated C-peptide help confirm type 2 diabetes in overweight and obese adolescents. This testing is recommended in all such youth with hyperglycemia. Mental health comorbidities are disproportionately common in young people with type 2 diabetes and require systematic screening and integrated care. Effective care for adolescents requires an interprofessional team addressing medical, nutritional, psychological, educational, and social domains. And social determinants of health profoundly influence diabetes management and must be assessed and addressed within the care plan. We will now review the exam questions to solidify your understanding. This review covers 10 questions from the Diabetes Management Continuing Education course. For each question, I will read the question aloud, provide the correct answer, and explain why that answer is correct. Question 1. The AAB-BCC framework is used to systematically evaluate clinical features when diabetes classification is uncertain. Which of the following is not a component of the AAB-BCC framework? The correct answer is cardiovascular disease status. Their AABBCC framework is a clinical mnemonic designed to help clinicians differentiate between type 1 and type 2 diabetes in ambiguous presentations. Each letter represents a specific criterion: age at diagnosis, with younger age below 35 years favoring type 1, autoimmune history, including personal or family history of autoimmune conditions, body habitus, with lower BMI below 25 suggesting type 1, background family history of type 1 diabetes specifically, inability to achieve glycemic control on non-insulin therapies, and comorbidities such as immune checkpoint inhibitor therapy. Cardiovascular disease status, while clinically important in diabetes management, is not part of this classification framework because it does not help distinguish between diabetes types at the time of diagnosis. Question 2. According to the American Diabetes Association's 2026 Standards of Care, which hemoglobin A1C level meets the diagnostic criteria for diabetes mellitus? The correct answer is 6.5% or higher. Rationale: the American Diabetes Association has established clear diagnostic thresholds for diabetes mellitus. Hemoglobin A1C of 6.5%, equivalent to 48 millimoles per mole, represents the cutoff for diabetes diagnosis when measured using a standardized assay. This threshold was selected based on the observed relationship between A1C levels and the risk of diabetic retinopathy. Values between 5.7 and 6.4% indicate prediabetes, representing an intermediate category of impaired glucose regulation. Values below 5.7% are considered normal. Understanding these precise thresholds is essential for accurate diagnosis and appropriate clinical decision making. Question 3. The American Diabetes Association recommends that screening for prediabetes and type 2 diabetes be considered in all adults beginning at what age, regardless of weight or other risk factors. The correct answer is age 35 years. Rationale. The ADA's universal screening recommendation at age 35 reflects the increasing prevalence of type 2 diabetes in the general population and the recognition that diabetes can develop even in individuals without traditional risk factors, such as obesity. Earlier guidelines often focus screening on high-risk individuals, but epidemiological data demonstrates that many cases of diabetes go undetected when screening is limited to those with obvious risk factors. By recommending universal screening at 35 years, the ADA aims to identify prediabetes and diabetes earlier in its course, allowing for timely intervention and prevention of complications. Screening should be repeated at minimum intervals of 3 years if results are normal, or more frequently if clinical circumstances change. Question 4. Which of the following best describes the renal protective effects of SGLT2 inhibitors? The correct answer is they slow progression of diabetic kidney disease independent of glucose-lowering effects. Rationale. Sodium glucose cotransporter 2 inhibitors represent a major advancement in diabetes therapeutics precisely because their benefits extend beyond glucose control. Multiple landmark clinical trials, including Credence and DAPA-CKD, have demonstrated that SGLT2 inhibitors reduce the risk of sustained decline in estimated glomerular filtration rate, end-stage kidney disease, and renal death. Importantly, these renal protective effects persist even at levels of kidney function where the glucose-lowering capacity of these medications is minimal. This observation indicates that the mechanism of nephroprotection involves factors beyond glycemic control, likely including reduced intraglomerular pressure through tubuloglomerular feedback, decreased tubular workload, and anti-inflammatory effects. This understanding has expanded the use of SGLT2 inhibitors to patients with chronic kidney disease regardless of their diabetes status. Question 5. Which statement accurately describes the hypoglycemia risk profile of GLP-1 receptor agonists? The correct answer is they do not cause hypoglycemia when used as monotherapy or with metformin because their insulin-stimulating effect is glucose-dependent. Rationale. GLP-1 receptor agonists work by mimicking the action of endogenous glucagon-like peptide 1, an incretin hormone that stimulates insulin secretion. The critical feature of this mechanism is that insulin stimulation occurs only when blood glucose is elevated. As glucose levels decline toward normal, the insulin-stimulating effect diminishes accordingly. This glucose-dependent action means that GLP-1 receptor agonists do not drive blood glucose below physiological levels when used alone or combined with metformin, which also has a low hypoglycemia risk. This favorable safety profile makes GLP-1 receptor agonists particularly valuable for patients in whom hypoglycemia poses elevated risk, such as older adults, those with variable meal patterns, or individuals in occupations where hypoglycemia would be hazardous. Question 6. In adolescents with type 2 diabetes, which comorbidity is most prevalent at the time of diagnosis? The correct answer is dyslipidemia. Rationale. Type 2 diabetes in adolescents presents a particularly concerning clinical picture because metabolic abnormalities are often well established by the time of diagnosis. Dyslipidemia affects approximately 80% of youth with type 2 diabetes at diagnosis, making it the most common and often the most treatment-resistant comorbidity in this population. The dyslipidemia pattern typically includes markedly reduced HDL cholesterol in over 80% of cases, elevated triglycerides in approximately 66%, and elevated LDL cholesterol in a smaller percentage. This high prevalence of dyslipidemia at such a young age contributes to accelerated atherosclerotic disease development and underscores the importance of comprehensive cardiometabolic management in youth-onset type 2 diabetes, not simply glucose control. Question 7. Compared to age-matched individuals without diabetes, young adults diagnosed with type 2 diabetes before age 45 have how many times increased odds of depression, bipolar disorder, anxiety, or stress-related disorders? The correct answer is 3.4 to 4.2 times. Rationale: the mental health burden associated with early onset type 2 diabetes is disproportionately high compared to diabetes diagnosed at older ages. Young adults with type 2 diabetes diagnosed before age 45 face 3.4 to 4.2 times increased odds of psychiatric conditions including depression, bipolar disorder, anxiety disorders, and stress related disorders compared with peers without diabetes. This elevated mental health burden likely reflects multiple factors: the psychological impact of managing a chronic disease during formative years, shared pathophysiological pathways between metabolic dysfunction and mood disorders, the social and lifestyle disruptions that diabetes management requires, and potential biological effects of dysglycemia on brain function. This finding emphasizes the critical importance of mental health screening and integrated psychological support in diabetes care, particularly for younger patients. Question 8. According to the course content, a systematic review and meta-analysis of continuous glucose monitoring in type 1 diabetes demonstrated an A1C reduction of approximately what value? The correct answer is 0.26%. Rationale: continuous glucose monitoring technology provides real-time glucose data that enables more precise insulin dosing and behavior modification. A comprehensive systematic review and meta-analysis examining 22 randomized controlled trials in type 1 diabetes quantified the glycemic benefit of CGM use at a mean A1C reduction of 0.26%, with a 95% confidence interval ranging from negative 0.37 to negative 0.15%. While this improvement may appear modest in absolute terms, it represents a clinically meaningful reduction that, when sustained over years, translates to significant decreases in microvascular complication risk. Additionally, CGM provides benefits beyond A1C reduction, including reduced glycemic variability, decreased hypoglycemia, and improved quality of life through reduced burden of frequent fingerstick testing. Question 9. A study on interactive online educational modules for nurses regarding insulin administration demonstrated which of the following outcomes? The correct answer is reduction in insulin error rate from 14.8% to 1.7%. Rationale: medication errors involving insulin represent a significant patient safety concern because of insulin's narrow therapeutic index and the severe consequences of both overdosing and underdosing. A pediatric study evaluated the impact of implementing a mandatory online educational module that taught nurses about insulin pharmacokinetics, proper dosing calculations, and administration techniques through interactive case-based learning. The results demonstrated a dramatic improvement in patient safety, with the insulin error rate decreasing from 14.8% to just 1.7%. This represents an approximately 90% reduction in errors. Concurrently, the hypoglycemia rate decreased from 5.9% to 3.4%. These findings provide compelling evidence that structured, interactive educational interventions can significantly improve clinical competency and patient outcomes in diabetes care. Question 10. According to the chronic care model, randomized controlled trials demonstrate that programs incorporating how many core elements achieve greater improvements in glycemic control? The correct answer is 4 or more elements. Rationale: the chronic care model is a framework for organizing healthcare delivery to optimize outcomes in chronic disease management. The model identifies 6 core elements: health system organization, clinical information systems, delivery system design, decision support, self-management support, and community resources. Research evaluating chronic care model interventions has demonstrated a dose-response relationship between the number of elements implemented and clinical outcomes. Specifically, randomized controlled trials show that programs incorporating 4 or more of the 6 core elements achieve significantly greater improvements in glycemic control than programs with fewer elements, with a mean A1C reduction of 0.21%. This finding supports a comprehensive, multi-component approach to diabetes care delivery rather than implementing isolated interventions, and it underscores the synergistic effects of addressing multiple aspects of care simultaneously. This concludes the exam review. Remember that understanding the rationale behind each answer will help you apply these concepts in clinical practice, not simply recall facts for the examination.